Doctors, we are live.
Great. Good morning and welcome everyone to on this rather early Sunday morning uh, for this, hopefully interactive webinar on, titled Retina case files. And these are, as the flyer suggests, going to be 10 cases, and they'll be spanning most of what retina has to offer, from medical retina to surgical retina to uveitis to ocular trauma, and also will touch on ocular oncology. So we hope to learn and share and disseminate knowledge amongst all of us, through this webinar, and hope to end up enriched by the time this webinar actually finishes. And without further ado, we would actually dive straight into it, and would like to introduce the illustrious panel that we have today, and starting with Raja Narayanan sir from LV Prasad, Hyderabad. Thank you, sir, for joining us today and taking out time. We have Dr. Sangeet Mittal from Thind Eye Hospital in Jalandhar. Thank you, sir, for joining us today as well. And the brain behind this entire program, Professor, and one of my mentors, Professor Ramandeep from PGI. Thank you also, sir, for conceptualizing this and giving all of us this platform to, come together and be enriched by this. So thank you, sir. And we dive straight into the first case, which is being presented by Dr. Swapnil Parchand, who is a consultant in retina and uvea at the MGM Eye Institute in Raipur, and is actually an alumni from PGI. Dr. Swapnil, please, if you would share your slide, and he will be talking to us or showing us actually two cases in which retinal vasculitis was actually the harbinger of sinister systemic pathologies. Dr. Swapnil, please.
Good morning, everyone. Dr. Mohit, my slides are visible?
Absolutely, sir. They are.
My voice is clear?
Very clear, sir. Please.
So I'll go on the first case. He's 42-year male, farmer by occupation, and he presented with blurring of vision in both eyes since 2 months. It was gradual, painless, and progressive. On examination, his visual acuity was 20/50 in both eyes. He has few cells in anterior chamber, and he has vitritis. On fundus examination, what we can see is there are multiple retinal hemorrhages. Few of them are white-centered hemorrhages all over the posterior pole. There is retinal vasculitis involving the larger vessel. And importantly, what we can see are a few yellowish-white granular retinal infiltrates in perifoveal area. Apart from that, we can see this, there is macular edema. So we can see clearly this granular retinal infiltrates. So if we see periphery, there is extensive retinal vasculitis associated with retinal hemorrhages. A similar picture was present in left eye also. This is the periphery. On OCT, what we can say is there is presence of macular edema. There are pinpoint hyperreflective lesions within the inner retinal layer, and these were corresponding to this granular retinal infiltrates. Similar picture was there in OCT in left eye as well. So clinical diagnosis at this point was posterior uveitis, retinal vasculitis, mainly hemorrhagic periphlebitis, along with macular edema. So differential diagnosis, what we can suspect is Behçet disease, tuberculosis, blood cell dysplasia, and sarcoidosis. So on retrospective history, this patient gave history of significant weight loss in last 6 months. We at that point of time, we started on topical drops, prednisolone and nepafenec, and we investigated this patient. So on complete blood count, what we can see is HB level is less. The total leukocyte count are quite high, and DLC is quite deranged. Platelet counts were normal. So peripheral smear was suggestive of chronic proliferative disorder, possible CML. On ultrasound abdomen, it was suggestive of grossly enlarged size. Spleen was grossly enlarged with normal shape and equal texture. So he was referred to hematologist for further evaluation. Hematologist prescribed bone marrow, and bone marrow revealed features suggestive of myeloproliferative neoplasm, suggestive of CML on chronic phase. And they also did BCR ABL quantitative analysis or peripheral blood with RT-PCR, and it was again suggestive of CML. So hematology started on allopurinol and hydroxyurea. So this was as presentation, and over a follow-up, his visual acuity subsequently improved to 2020 at the end of 2 months. His retinal hemorrhages started disappearing, and as well as his retinal infiltrates. So this is my second case. He is again 42-year-old male, presented with sudden painless loss of vision since 1 week. He also had a loss of weight and appetite for 3 months. On examination, per abdominal examination, he had hepatosplenomegaly. This is fundus picture. What we can see is floric NVD, neovascularization of disc, a few scattered retinal hemorrhages over the posterior pole, and we can appreciate retinal vasculitis as well. And mainly, if you see nasal part of retina, we can again see similar kind of granular retinal infiltrates, which are actually looking like a clumps. This is picture of left eye showing NVD, vasculitis, and retinal hemorrhages. So again, this patient also had low HB count, and his TLC was quite raised, DLC was deranged, and peripheral smear again was suggestive of CML. So if we see the literature, there are not much reports which present CML or retinal infiltrates as a presenting feature of CML. This is one of the publication series of patients of leukemia published in ophthalmology. Out of 38 patients of CML, only one patient has leukemic retinal infiltrates, whereas none of the patient reported as retinal vasculitis. So what we can gather from both of my case is that vasculitis in CML is mainly involving the vein. It mostly is hemorrhagic periphlebitis. It involves large as well as small vessels. They have dense perivascular cuffing. They are associated with granular retinal infiltrates. We can see NVD, and of course, we rod spots are pathognomic of leukemia. So thank you for your patient hearing.
Thank you, Dr. Swapnil, for those two excellent cases. I think they were very well documented, and I think they were crisp, and they drove home the point that you wanted to talk about. So thank you, sir. If you would kindly stop sharing your screen, and I'll just throw this up, this open for discussion to the panelists, please. I would like to, get Rajan Narayanan sir in first, and ask for his views on these two cases, and also pose a query to him. So some of these lesions might look like CMV retinitis lesions, and patients with CML might have CMV retinitis also, whether they are treated or they are treatment naive. So how can one look at maybe clinically or otherwise differentiating, or any other clues or pointers that one might be astute to, sir?
Yeah, very nice presentation, Swapnil, and you have brought out a very important point that whenever you have a bilateral presentation of multiple hemorrhages, sometimes they look like CRV also, in the sense lots of hemorrhages. But if you see very carefully, why should a patient develop bilateral picture like that? And when you may have sometimes some venous tortuosity, and those very fine yellowish white lesions which you mentioned about granularity, those should immediately raise suspicion of a blood dyscrasia. So any blood dyscrasia can cause. In fact, the more common ones are the CML and sometimes AML. Uh, Very rarely you may have to consider even anemic retinopathy, but they usually won't have too much of that kind of intense hemorrhages which you have noted. There will be more like blood hemorrhages. They may have white centered hemorrhages. But again, the important point that you have brought out, the message is, whenever patients present with bilateral picture of, let's say, a CRV or a venous stasis, it should immediately alert you to a systemic disease and not just do an OCT and keep treating with anti-VEGF injections. But coming back to Mohit's point, again, when you see too many intense hemorrhage, like in CMV retinitis, you will see retinitis patches and some hemorrhages depending on the type of CMV retinitis that you are seeing. But when you are seeing more hemorrhages, bilateral, almost symmetrical with venous congestion, that means there is a venous, coagulopathy, or there is a blood dyscrasia going on. If I can share my screen actually at this point of time, I would like to show some images of mine. I'll just, yeah, so I hope you can see my slides, and these are some different variety of cases. I mean, this is not exactly the same way your patient has presented, but sometimes you can have infiltrative optic neuropathy. This is a patient of AML actually, and both eyes no light perception. So this is one variety you can see. Then the other variety is that, like, you can see this lots of hemorrhages, but again with an optic nerve infiltration again, but with hemorrhage. So whenever you have infiltrative neuropathy, you must consider a systemic pathology and not just treat them like you would otherwise treat them with anti-VEGF sometimes in these cases. Again, look at these hemorrhages. A lot of them have white center in them, but the hemorrhages can have varied presentation, like the one you showed, and they may have periphlebitis kind of picture, but the hemorrhages are not the typical CRVO kind of hemorrhage that you will see. This is the other eye of the patient. Again, you can see disc infiltrate here. But then I will show you one more case. Yeah. So if you see here, this patient also has a lot of these white centered hemorrhages or those granularities, not just white centered hemorrhages that you can see. And you can see in the blood vessels also, there is some perivascular infiltration. So these are the cases. This patient actually turned out to be having CML. But again, any patient where you see there are no other risk factors for a CRVO bilateral presentation, and there are many hemorrhages with white center or some granularity, those should immediately raise suspicion, and you did the right thing actually. So the message to the audience is that don't look at every patient as something which can be treated with anti-VEGF injection. Always dive deep to find out what could be the cause of these occlusions. Even BRVO, actually I was surprised in one case in a conference in Israel where they showed bilateral BRVO. I mean, patient is normal hypertensive diabetic. We see bilateral BRVO, one eye at one time, another at another time. But again, that patient they showed had a leukemia, so you must be alert. Just rule out. There's no harm in ruling out and doing a peripheral smear in these cases.
Absolutely, sir. Thank you, sir, for those for sharing your screen and showing excellent cases as well. I'll now, like to throw this out to Ramandeep, sir. So you have a lot of experience, and I'll just little bit, off the topic of adult CML, but you also deal with a lot of pediatric leukemia cases, sir, with your collaboration over the years with the Advanced Pediatric Center patients. And if you would just like to share your experience regarding and a few pointers as to how we can maybe pick up, cases earlier in the pediatric age group, sir.
I think most of the points Dr. Raja has covered, but nice slide by Dr. Raja and Dr. Swapnil. But one thing which reminds me, the eye is the window of the human body. This we must all remember this thing. There are certain signs which we see in the eye, and we can somehow predict that this is what the systemic diseases can be there. So adding a simple test like CBC in these young patients, like Dr. Raja said, in the bilateral and with the lots of hemorrhages, with the with the venous stasis type picture, and in the kids, like the Mohit said, I'll come to that point straight away. In the kids, the greatest worry is there. They are on immunosuppression, and the pediatrician is worried that whether it's an infectious disease is occurring or it's a infiltrative disease occurring, and that is the clue there. So, like so the presentation can be of an infiltrative optic disc disease, like Dr. Raja showed. If you moment you see infiltration in the disc, then you have to tell the pediatrician this is a recurrence in the brain, so you must go for it. And then if you see these hemorrhages with NVD with subhyaloid hemorrhages, you miss that subhyaloid board-shaped bleeds. In that paper, the board-shaped bleed is one of the is a sign there. So if you see those signs, it's probably due to the disease per se, and it is not due to the infectious. And CMV, once you see CMV cases, you will never miss it in these eyes, because it is certainly a different picture. You will not see these white-centered hemorrhages scattered all over and venous stasis. So I think it's clinically you can make out most of the things. Mohit, I hope I've answered all the questions.
Absolutely, sir. And Sangeet sir, any point from you regarding this? Any treatment related nuggets that you'd like to give after we have diagnosed, sir? We have, the most important point, as was brought out by the panelists, were to find the underlying cause. But after we have found it out, is there a role for treating it with anti-VEGFs or with steroids or anything else along? I mean, of course, primarily treating the patient for the underlying disorder, or do we hedge our bets and just first try and get the hematological parameters in under correction, and delay treatment as far as the ocular features are concerned?
Yeah. I think my primary thing is to treat the disease per se rather than treating the retina at this time. But I don't know, I may do a FFA just see any ischemic areas are around or not. And if there are any ischemic areas, might do some laser also. Anti-VEGFs, I don't think will have any role because it's not a occlusive disease as such. One more thing I'd like to add is sometimes leukemia can also present as a frosted branchitis. One case I remember, he had a very severe frosted branchitis in both eyes, which turned out to be leukemic infiltrates along blood vessels. And that is another presentation which can be there for leukemia. But the one thing that is that Dr. Raja has also pointed out, and Swapnil has also pointed out, is that bilaterality in the disease often suggests that it's a systemic underlying cause, whether it's an inflammatory or whether it's a neoplastic or anything. And we have to investigate for that and not just go ahead and treat with anti-VEGFs.
Thank you, sir. Thank you for those.
I think FFA would have been an additional investigation in these.
I would like to add that first case actually did had a bleed on subsequent follow-up. He was lost to follow-up, and then he again presented with vitreous hemorrhage. So I did a vitrectomy, and post-operative, of course, I did a laser, and post-operatively I did a FFA, which was suggestive of a lot of CNP areas in other eye as well. So I did a laser PRP in other eye, and this side underwent PPV.
So one interesting point, if I can add, Mohit, it's related to COVID. I had one young boy who presented like a month ago, and I think Apurva has also raised an important point. We'll come to that. But 1 month ago, he came with his father, and then when I saw he had bilateral kind of CRO picture, and I was like, this has to be investigated now right away. I have to take him to the physician. This was like what we are discussing now, and I will make sure that he has a systemic disease found out right now. I mean, they did not give the history of AML at that time. And then gradually started asking more questions. What happened? Why did he have any problem earlier? Then he showed me a bunch of papers, and in that it was written AML. And the last chemo he took was last year. And then my enthusiasm fell down a little bit that, I did not diagnose. He's already diagnosed. But then the point was that due to COVID, he missed 2 cycles. And his father was saying, the last time we did his CBC was all right. Ye dekhiye aap, his leukocyte count. I said, that was like 4 or 5 months ago. But then we picked up that he needs, he has recurrence probably, and then he needs to be sent to the oncologist again, hemato-oncologist. But then after that, he has not followed up again. Very unfortunate. All these things, whenever there are leukemias, COVID, it's, at least as an eye center standalone, it becomes very difficult to coordinate with everyone. But then this can be, as Ramandeep pointed out, that you need to be very careful. Even if it's a diagnosed case, we may be able to tell what's going on with the body before they even present to the oncologist again for further checkup. So that's an important point that I wanted to make. So Apurva, you can go ahead probably with your comments.
Yes, sir. Just like I said in my comment, many of our PDR patients, I don't know if I should say many, but some of our PDR patients seem to have CML as well. And these patients have a much more florid PDR and much worse membranes who have a lot more bleeding than usual. And we fail to see sometimes that these patients actually have clues of some dyscrasia because of the atypical hemorrhages that they have, which we see intraoperatively carefully, which you have cursorily seen and passed away as PDR. And ever since we've had some 2-3 patients and burnt our fingers, we are doing a peripheral smear in all our PDR patients. And even the vitreous hemorrhage in these patients, it's not red, it's ochre yellow. I don't know if the panelists have similar observations to make.
Yeah, very important point you have raised, Apurva, in the sense the PDR patients can have leukemia and CML basically. And what we see in these patients is the numerous hemorrhages that they have. Unlike some PDR patient, we see that they will have some dot blot hemorrhages, NVD, NV. But these kind of patients, what Swapnil showed, if you see that kind of massive hemorrhages in these patients, again, they may be having also white center and some perivascular exudation may also be there. But whenever you suspect a bilateral, you are not sure, is this CRV or PDR kind of doubts when you start having. Please do go ahead for CBC peripheral smear. We are not generally going in for, in general, CBC for all PDR patients, but whenever we have suspicion, we are going in for that. So overall, I think you have to look at the clinical picture, which you have raised. A very important point, Apurva, that you cannot just assume and imagine every patient of PDR has only PDR.
One more thing I'd like to add to what Dr. Purva has pointed out is that she has burnt fingers. I had also burnt my hands doing the PDR and leukemia, which were together in 2 patients, I think I remember.
Yes.
Are so thick, they are so attached to the retina, you cannot, it's not possible to separate them. And 2 patients I lost just because of this, and I've now stopped patients who have both the things together, diabetic retinopathy as well as CML. I've stopped operating them now when I've burnt my finger. You're absolutely right. It's very difficult to operate.
Absolutely. Ashish, are you ready with your presentation? Thank you, everyone. Thank you, Purva, for the comments. Ashish, are you ready with your case, please?
Yes, sir.
Yes, Ashish, please, you can share your screen and then we can. So the next case is going to be by Dr. Ashish Markan. He's currently with us here at the PGI in Chandigarh as a second year MCH Vitro Retina Fellow. And he's going to be, we all know about, siderosis in the eye. He's going to be talking about a siderotic vitreous. So let's see what Ashish has to say. Ashish, please.
So, very good morning to all. So, at the outset, I'd like to thank Mohit sir and Professor Ramandip sir for giving me a chance to present my case here at this wonderful platform. So, I'll be presenting a case of a 25-year-old male who presented to us in August 2020. He had a history of a probable hammer chisel injury in the left eye while working about 3 months back. He was diagnosed as a case of closed globe injury outside and was managed conservatively. Now, the patient presented to us with sudden onset diminution of vision in the left eye from last 7 days. He was diagnosed as a case of left eye rhegmatogenous retinal detachment outside and was planned for buckling surgery. Patient came to eye center for a second opinion. So, on ocular examination, the right eye was absolutely normal. The best corrected visual acuity was 6/6, and the posterior segment showed presence of a superior lattice. Whereas in the left eye, the best corrected visual acuity was hand movements close to face. The intraocular pressures were 14 millimeters of mercury. And the posterior segment findings I will be showing in a subsequent Amsler-Dubois chart. So in the left eye, the patient had a total rhegmatogenous retinal detachment, which was quite bullous with presence of a superior lattice with holes. Also, the retina had a slightly brownish discoloration and there were presence of these multiple golden yellowish particles in the vitreous cavity. So as the patient had a history of hammer chisel injury, so we suspected that probably patient had a self-sealed scleral perforation at that time and had a retained intraocular foreign body. And these golden particles could have disintegrated from the surface of the foreign body and they have come into the vitreous cavity, though any definite foreign body could not be localized clinically. We also got a USG done and ultrasonography through these particles showed a very high spike with a posterior backshadowing, suggestive of metallic nature of these metallic nature of these particles. But again, we could not localize the foreign body, and we got a NCCT head and orbit. And NCCT head and orbit revealed a large intraocular foreign body which was present in the infratemporal quadrant, just behind the lens at the pars plana. So as there were these multiple metallic particles in the vitreous cavity, and also the retina had slightly brownish discoloration. So we thought that the ocular siderotic changes have started to set in. So we made a diagnosis of left eye retained intraocular foreign body with ocular sidrosis with rhegmatogenous retinal detachment. And so patient was planned for a parsplana vitrectomy with a gas tamponade. So I'll be showing the surgical video. So after 360-degree peritomy was done and a 240 band was passed, 25G ports were made. So there were no evidence of any open globe injury in the eye. So after the core vitrectomy was started, here we can see that there were multiple golden yellowish particles in the vitreous cavity. What was surprising was that all these particles, they could be easily eaten up with the vitreous cutter. So after a subsequent amount of core vitrectomy as well as mid-peripheral vitrectomy was performed, so tricot was injected onto the disc to look for PVD status. So PVD was already present. So here we can see the retina is so brownish and had a brownish discoloration. So as the retina was quite bullous, so I decided that I'll do first a fluid exchange to flatten out the retina so that the details can be clearly visible. So after the retina was flattened, then I went ahead and performed the rest of the vitrectomy in the mid-peripheral as well as the peripheral areas. So here you can see the vessels are totally sclerosed in the infotemporal area, and there were these pigmented patches. So on depression in the infotemporal area, there was this clump of yellowish material. So after I shaved off this material, I could see an underlying foreign body. So this foreign body was then isolated and was separated from the that clump of yellowish material. So once the foreign body was isolated, then I injected PFCL bubble on the disc as well as macula, and then using a chandelier light and with the help of an intraocular magnet which was inserted through a sclerotomy, and with the help of a bimanual technique, uh, the foreign body was taken out of the eye along its longitudinal axis with the help of end gripping forceps. So after this, the sclerotomy site was sutured, the PFCL bubble was removed from the eye, and finally a fluid exchange was performed to flatten the retina. Once the retina was flattened, then finally the retinotomy as well as the superior lattice with holes, they were lasered, and a 14% C3F gas was put as a tamponating agent. So this is the post-operative image of the patient at 3 weeks. So there was about 50% gas fill. The retina was attached. Also, we could see that in the infratemporal quadrant there were these sclerosed vessels, and also there was this pigmentary lesions or pigmentation which was present in the subretinal space in the infranasal quadrant, suggestive of some sidrotic changes. So my take-home message is that we must look for occult signs of open globe injury and suspect intraocular foreign body, especially in cases of a suspected hemorrhageal injury. And the changes of ocular sidrosis can set in early, and the localization of foreign body requires a detailed clinical as well as radiological investigations, and we must plan our surgery accordingly. Thank you.
Thank you, Ashish, for that wonderfully done surgery, and kudos to you on that. And before I'm actually going to go straight to Sangeet Mittal, sir. But before I do that, I'm just going to take the liberty and answer Veer's, query that he had put up regarding the previous talk. I'm sorry I missed it. So he's actually asked, is it worthwhile doing a peripheral smear for all vascular occlusive diseases as a routine practice? I would say no, because I think if you're looking at a vascular occlusive disease, it would include inflammatory and non-inflammatory both. So if you're looking at inflammations, I think there is enough data out there to suggest that if it's a primarily occlusive retinal vasculitis, then given our, kind of setup, you're looking at tuberculosis, Behçet's, maybe some other things, but, a primarily occlusive retinal vasculitis is not something which you're looking at. A hemorrhagic retinopathy, I think, which is bilateral, which is what the panelists had also alluded to, absolutely. Extremes of ages, atypical presentation in which there is a bilateral hemorrhagic retinopathy, CRVO like picture, tortuosity of vessels, or associated granularity, absolutely you should. As far as occlusive retinal disease is concerned, it doesn't hurt, but I don't think a primarily occlusive disease without too many other things would be one of the manifestations of CML. With that,
comment. I asked that because Raja sir mentioned that even BRVOs which are bilateral. So if you have any suspicion, I thought maybe that was a relevant question.
No, absolutely. That's great. I think thank you, Veer, for posting that, man. So again, coming to this presentation, I'd like to go straight to Dr. Sangeet, sir. So you've done, I think you have the maximum experience as far as dealing with intraocular foreign bodies is concerned, your proximity to JNK, I think after Amritsar, you get to see a lot of these patients. Again, I'd like to you to give your pearls, sir, and your comments on
One
managing
thing, Mohit, like all these pellet foreign bodies are not iron and they don't lead to cirrhosis, but definitely what he has pointed, what Dr. Ashish has pointed out, is this golden glow. Sometimes when you see in a patient of a trauma, you suspect intraocular foreign body, and I've seen this happening. I've operated all these cirrhosis patients where everything is brown. The cornea is brown, the lens is brown, and you have to do everything. You have to do the transplant, you have to remove the lens, and then you have to tackle the retina. One thing more is like in these patients, when you do an indirect ophthalmoscopy, when you do an indirect ophthalmoscopy and you see that golden thing present in the vitreous or on the retinal surface, you suspect that there is a foreign body, and you have to plan accordingly. Two more things. One thing, that the retina is very fragile in these cases. The older the trauma, the retina becomes very fragile due to this cirrhosis, and you have to take care when you are operating the retinal detachment. In these cases, it just behaves as you are operating an ARN case. Sometimes it's just like that. So these things you have to take care. You have to sometimes remove the lens. Sometimes you have to do a planet transplant together, because the view is very bad in these cases.
Absolutely, sir. Points taken. Raman, sir, any pointers, any points from your side, sir, regarding the case?
So, what I was, looking at this at a different angle, is it cirrhosis of the vitreous? No. So this is just a simple encapsulation of the foreign body, what we see. What happened is, over the time, this is trauma was something somewhere in May. So you have encapsulation around the foreign body, and that's a kind of a savior also. Encapsulated foreign body doesn't cause cirrhosis, but they do because the size is very big. So some of the iron gets into the fibrous capsule also. In this patient, because of the PVD, and this capsule somehow got broken, and some of these capsular particles are mixed with iron, came into the vitreous. So these golden things are usual, encapsulated foreign body components. This is what I feel, because nobody has documented that vitreous per se. They've shown that vitreous degeneration can happen, but it would have been better that you could have sampled these particles, sampled the vitreous, and shown that there is a ferric ion there, and it would have been wonderful. But yes, the sidrotic changes can occur to the underlying RPE and salt and pepper fungus, but these golden things are nothing but the fragments of the capsule. This is what my take on this case is.
Absolutely, sir. So we stand corrected, Ashish, when we said that it's sidrotic vitreous. It's not, as sir rightly pointed out. Raja, sir, can I have your comment?
It's debatable.
Absolutely, sir.
This is what I feel.
No, absolutely, sir. Agreed.
But one thing, Dr. Raman, I'd like to add is like this type of encapsulation, this golden, is generally seen with iron foreign bodies, not with other foreign bodies.
Absolutely.
A lot of glass foreign bodies.
Absolutely. Raja, sir, can I have your comments on? So there is also a question regarding this, in the chat box that's been posted by Dr. Priya, and the question is actually regarding the role of ERG. I'm just going to extrapolate the question, and so one thing is to, if a patient has very good vision, 6/6, and you're not sure whether it's a or not. And you want to monitor the patient, is the role of ERG in that setting. And this question in which it's been asked that in the post-operative period, after you've removed, like in this, I believe Dr. Priya asked, if particularly this case, in the post-op period, the fact that there were so many pieces, although a complete vitrectomy was done and everything was removed, is there a role of serial follow-up ERGs in the post-op period in this patient?
Yeah, again, very good question. In fact, this one case can take the discussion in so many different angles. But one thing which I feel the main objective, probably among the others, is that when to suspect. So if you don't suspect, you will miss many things. So right from the history itself, when you say chisel and hammer injury, even if the patient says, no, no, it fell down, it hit my eye and came out, no way that you can accept the patient's history, or the first ophthalmologist finding that there is no, everything is normal, we checked inside the eye, there was no problem. So at this point of time, I would say that whenever the Ramandeep, he brought out a very important point, that sometimes even if there is good encapsulation, it can be
Absolutely.
savior for the patient. And I have left some cases where they are coming after 3 years
Yeah.
and saying that, on X-ray and CT now they have found foreign body, and I see only capsule stuck to retina choroid, and if you try and go and remove, you will only damage more than what you are trying to do. That's one angle or one extreme where, some naturally the patient may do well, but in many cases we are not suspecting because we assume the patient is right, or the first ophthalmologist who are mentioned that no abnormality detected was fine. So either iris hole, or even if there is a slight chemoceral subconjunctival hemorrhage, chisel hammer injury, better to get an X-ray if not a CT scan.
Yeah.
I will just show you one, if you permit, one video. I'll
Please,
share one screen,
please.
and the topic, or the what I mentioned here is that to suspect is my job. So I'll just show the video. This was a patient who came to our cornea colleagues, and they repaired the scleral tear, and they found that there was some conjunctival reaction, or redness was not going away, and they thought that the reaction, AC reaction, was more. So then they referred to us, is there any endophthalmitis? So the point was that after a week of the scleral tear repair, this patient was sent to us, and then I took on this with my fellow Anirudh, who's currently my fellow, did a great job, and we have opened up now just to see if there is any sign of any foreign body or anything else amiss. It was bleeding a lot, and if you see, the eye otherwise looks quiet, no iris hole or anything. But then we went inside, there was some vitreous hemorrhage, but right near the pars plana. That's where you need to suspect. First of all, you suspect based on the history. Then you look inside. When you see do the vitreous, you see something projecting, it's not looking like a foreign body. But if you are not going to go after it, and you say, oh, a fakey young patient, 25, 30, or I don't want to damage the lens, it's just like some, you may think it's a granuloma or condensed hemorrhage. No, I said, no, we will not leave this. I mean, we didn't have at that time, this was posted for query endophthalmitis. Nobody even suspected a form. I said, I'm not taking him out of the OR without removing that material. And there we had to sacrifice the lens. We had to cut out the iris also, and then you will see that we started having a glimpse of the foreign body, and then we removed this. So I mean, obviously, if we have a CT scan prior itself or an X-ray, we will definitely make sure that we have removed it. But we, unfortunately, I was in the operation theater, this was that posted for query endophthalmitis, just check what's going on. So but then this was, we had to suspect, our job was to suspect based on the history, and based on what's going on there in the pars plana area, we had to remove that. So the point here is that, whenever you have a strong suspicion on history, and even sometimes, as has been mentioned on exam, you have to do, and you may have to do sacrifice for that. But coming to ERG, once you have done, your patient has retinal detachment, obviously its interpretation becomes very difficult. And sometimes, ERG changes would be there whenever you have patients with siderosis, it will be there. But follow up patient also, once you put silicone oil or something, the oil reduces the electrical conductance. So the wave, at least the amplitude, will not be good at all, even once you put the silicone oil in these cases. But if you put gas again, once the gas goes away, yes, you may be able to check. Only if you're suspecting multiple foreign bodies, in the sense there may be sometimes multiple foreign bodies also, and if I have not been able to remove all of them, it can give a clue that if it is worsening, yes, it can give a clue. But usually these kind of injury, chisel hammer injury, usually they are only one foreign body. What you see as diffuse ones, those are like, not multiple during the time of injury. They may dissolve a little bit here and there. But overall, I would say ERG is a very difficult thing to monitor when it complicates retinal detachment. Even after settling the retina, ERG may be subnormal once you have reattached the retina.
Absolutely, absolutely, sir. Absolutely.
I think for the young fellows, I think the most important thing, Mohit, before moving on to next case is X-ray. We should remember that radiologically we should get X-ray for each and every case of where a suspecting the earlier we used to get it done, and I think we should do this activity. X-ray is very important. Yeah,
Very good, very nice point. Just one of the cheapest things, get an X-ray. It's very, very sensitive.
And it also has very serious medical legal ramifications if we tend to, unfortunately miss it. So that's also absolutely so. The point is very well driven there. Absolutely, absolutely. So with that, a little bit of a change in schedule. This is for the audience. So as per the flyer, the keynote talk by Dr. Sangeet Mittal was set to take place after 5 cases were over. But we actually, it was actually Sangeet sir's idea, and I think a great idea at that. So he actually has multiple videos, showcasing his surgical skills using the 27 gauge system. So we have actually broken them up into 4 groups, which will kind of mirror the cases which have just happened. So the first lot of those, sir will be presenting, which will be ocular trauma. So can I request Sangeet Mittal sir to please share a slide? And while he's doing that, can I have one question with Dr. Raman, sir, please, since it was your work, which I was also a part of. So there's this question in the chat box by Raghavendra regarding the role of autofluorescence that might be there in to rule out or to look at diagnosing CMV retinitis as opposed to in patients with hemorrhages and all of that. So since you have your publication on that, sir, can I have your comments on that?
Raghavendra, if you make it zone 1, 2, 3. In zone 3 in the periphery, you will not be able to do a good FAF because of the various reasons. So FAF works for the zone 1 and zone 2. It doesn't work for the hemorrhagic disease, only works for the granular variety of CMV retinitis. So if you have a granular variety of CMV retinitis, if you have hyper FAF, that means the lesion is active, and if there is a hypo, that lesion is probably healed. It works only for the granular variety, not for the hemorrhagic variety. So in these hemorrhagic varieties, they will be blocked FAF.
Absolutely, sir. So no role in this, Raghavendra, as was said. So Dr. Sangeet Mittal, sir, please.
Hi, Mohit. Is my screen visible?
Yeah, absolutely.
Oh, okay. So my topic today for this presentation is 27 gauge vitrectomy in complex scenarios. Actually, I have a little although I don't have any financial interest, but this topic is basically related to the Constellation machine that we are using from Alcon, and Alcon is the sponsor of this webinar. So it's not totally unrelated. And in this presentation, whenever I used to tell people do a 27 gauge vitrectomy, they will always say that we'll try it in some simpler cases. But so now in this presentation, I will be showing a few cases which were not supposed to be done by 27 gauge vitrectomy. My aim is to dispel the myth that 27 gauge vitrectomy is insufficient to perform such complex surgeries. And along with this, I will show a few tricks on how to handle situations using small gauge vitrectomy, not limiting it to the 27 gauge only. And I'm pretty sure that these tips will be useful to everyone. So why 27 gauge? The cutter is smaller and the port is bigger and closer to the tip. And it has got a fast cutting rate and a low flow rate. So whatever this cutter 27 gauge lacks in size, it gains in its agility and its low sphere of influence. And the flow rate is so low, it is 7 times as low as compared to a 23 gauge vitrectomy. And that makes it very easy and very safe to perform vitrectomy when you are very close to a mobile retina. And then the beveled probe, which it increases the surgical versatility of this cutter. It enables closer working distance to the retina and it improves access to the tissue plane. It just acts like a spatula. See, when you are operating in PDR cases, the membranes which are tightly adherent, this cutter allows the surgeon to lift up the tissue and then access the space between the membrane and the retina. and it acts like a vertical scissors just by cutting the membranes with efficient segmentation, and you don't need the scissors at all. And it also sometimes controls delamination of membranes. If you just put the cutter radial to the membranes, you can even delaminate the membranes as well as segment them. So in short, I'll just say that this vitrectomy cutter acts like a Swiss knife. It can be used for cutting and removing the vitreous, can be used for segmentation and delamination of membranes. It can be used even for peeling the membranes, for SRF drainage or air fluid exchange, even for dye injection, and it avoids the need for scissors, backflash, and even forceps sometimes. And by avoiding multiple entries of multiple instruments into the vitreous, it saves time also. So cosmetic advantages of doing a 27 gauge vitrectomy: it causes less trauma to the ocular surface. It increases the wound stability. It's more post-operative comfort. It's an easier entry into the eye. You don't have to get beveled incisions also, because the incisions are very small and close very nicely. And it causes less leakage, which is incarceration and hypotony. And there are, because of these things, less chances of post-op infection. But the main advantage lies in these surgical advantages, like in PDR with extensive tractional detachments, because of the small sphere of influence of the cutter and very small size of the cutter, which allows it to go in very small spaces that are available when the membranes are attached so close to the retina, or to these nails that are there in the PDR are placed very closely to each other. Or in combined retinal detachments, because of the low flow rate, you can operate very safely in case of a mobile retina. In DME and membranes, it is easier to grasp, peel, and dissect the membranes with the cutter itself. And in combined procedures, because of the small ports, there is a decreased post-op hypotony, and it avoids the use of air for sclerotomy closure. Sometimes we do put some air in the vitreous cavity just to close the ports properly, and you don't need to do that with a 27 gauge vitrectomy. So coming to the complex scenarios, this is the first case, trauma with intraocular foreign body, which was incarcerated in the retina, a 28-year-old male. And this we are doing 27 gauge vitrectomy. The vitreous hemorrhage was cleared, and you see this, the foreign body was embedded in the retina. It was brought out from the retina, and whenever you will bring out this foreign body from the retina, you will see some amount of bleeding. So I prefer, whenever there is a deep impact trauma, I prefer to do a chorioretinectomy along with the removal of the foreign body, because it prevents later development of PVR changes from this wound site which is present here. So you give 100% deep diathermy burns, and then you do a chorioretinectomy with the cutter itself. You can remove the choroid and the retina up to the level of the bare sclera. You have to do this chorioretinectomy. So you see, I'm exposing the sclera here with the cutter itself. This bleeding that sometimes happens during this can be easily controlled by raising the bottle height or applying more cautery in this areas. So once this is done, now I make another sclerotomy, additional sclerotomy around 2.5 millimeters in size, and introduce this foreign body removal forceps. And by the handshake technique, lifting the foreign body with the suction, and then using the forceps to bring it out from the eye. And then in the end, a fluid air exchange. And you even don't need to do laser around the chorioretinectomy, although I prefer to do some laser. But Dr. Ferencz, who has propagated this technique, does not do even the laser around this chorioretinectomy. He says that the diathermy is quite enough for sealing this wound. And this is post-operative. This patient was 6x6 post-operatively. This is another case of trauma with a knife. This is a 23-year-old male, knife injury with retinal detachment with vitreous incarceration. And you see here, there was a large vitreous incarceration, both the anterior and the posterior vitreous incarceration was seen. And in this case, again, with the 27, we are operating with the 27 gauge cutter only. And again, this 100% diathermy burns are given to perform first a retinectomy, all along this incarceration side, the posterior incarceration side. So you give the diathermy burns and then do perform a retinectomy. And once the retinectomy is complete, then and the incarceration side is totally freed from the retina, you just still the incarceration is not completed. So you just complete the, with the cutter, you can do this retinectomy and then remove the vitreous. Then you do again a diathermy around this incarceration site, just around around a millimeter or so around this incarceration, all over all 360-degree around the incarceration, and this will prevent the PVR to happen in the post-operative period. So after doing this, just manage it just like a giant retinal tear. Even you don't need to use PFCL, you can just use air because there is no eversion of the posterior flap. And once the air is done, you can do a 360-degree laser. And in the end, you can exchange your air with the silicone oil in this patient. And so this is 3 months post-operative and best 1 year post-operative. The best corrected vision was 6/36 in this patient. And this is a few days ago only came and showed to me he's maintaining his vision of 6/36 in this case. So I'll stop here and then just stop share. And open this for discussion on these two cases. My motive is to show that these type of difficult cases can be done by 27 gauge vitrectomy. Yeah.
Thank you, sir. Thank you for those interesting videos. I have one comment to make on that. I'll just come to that. Before that, I just have one question for Ashish from the last case. It's actually been asked by the audience. What was the functional outcome in your patient? I think they want to know that, you know, how the patient did. You were able to put back the retina, get the foreign body out. It looked very, very good. But given that the, you know, vessels were sclerosed, the retina looked sclerotic, they want to know what was the functional outcome in your patient, Ashish. Ashish is, I think, not with us as of now. So I think we'll come back to that once Ashish joins us. I just had one comment to make. It's a great surgeries as always, Sangeet sir. And I think chorioretinectomy is something which has been, as you rightly said, been propagated by Dr. Ferenc Kuhn, who has done a lot of work on ocular trauma and is not taken up that well by a lot of people. But I think for posterior pole, peri-posterior pole related trauma, you know, especially superior inferior temporal, where the drag on the macula, the fovea is almost a given. You know, given the quantum of inflammation, if we don't cut out the full thickness of retina and choroid, I think it's a great technique. I just had one small comment to make, sir, and maybe a concern from my side that if once we have exposed areas, and especially like in the second case, larger areas of the retina and the choroid, basically bare sclera, especially once we are working towards the equator, and if the area exposed is large, there is a chance of air embolisms during fluid air exchange if we you know tend to, because there are the vortex vein ampullas tend to be exposed because they lie right there. So just was my concern that either the fluid air exchange bottle height or the pressure of the infusion should be lower, or just a PFCL oil exchange can be done to completely circumvent and not let air into the eye. And it's not a very commonly reported thing, but it's unfortunately fatal, and it's something that quite frankly as ophthalmologists I think we aren't geared to deal with if God forbid we meet with that eventuality, sir.
You are right, Mohit. I think this is a serious risk. The PAVE syndrome that is supposed to be associated with the large choroid excisions. And peripheral things, peripherally large excisions, need to take care. Even if you are exchanging air, I think the air pressure should be very low when you are doing it. And as you rightly said, if you're using PFCL, then direct PFCL silicone oil exchange is another way to avoid this complication.
Raman sir, Dr. Raja, can we have your comments on your comments and your maybe critique on Sir's patients, Sir's cases, although I think there's no critique, they were accidentally performed cases, sir.
Raman, you want to go ahead?
Yeah. I mean, it's an excellent technique. But earlier we used to do a lot of these ILM peeling and do everything to take care of that future pucker. Because the future pucker and traction on the foveal center is the major worry when we are working with these foreign bodies near the posterior pole, because peripheral foreign bodies can be taken care with the encircle arch, but as the posterior foreign bodies, for them we have to do these kind of maneuvers, either do a 360, the all around retinectomy and adding a chorioretinectomy. I don't have any personal experience, but I have seen these videos and I think they perfectly work well. Yeah.
Yeah, very nice videos from Dr. Sangeet Mittal as usual. Very high quality, very high resolution, and good message is coming out from that. In terms of both 27 gauge and the foreign body, usually a lot of the practitioners don't want to keep too much of inventory. When I say inventory, in the sense, as long as your case selection is fine and you know you can finish one case with one particular gauge, and 27 gauge is very good in the sense you can go very close to the retina, you can go into smaller planes, it's very good. But whenever there is a doubt, like thick vitreous hemorrhage, uh, I know that definitely, even I don't go in for 25 gauge. Some of these PCV breakthrough hemorrhage, the previous discussion on ochre colored hemorrhage of CML PDR kind, very thick hemorrhage, even they tend to get clogged, and the light pipe gets stuck to the cannula. It doesn't even go in or come out. You have to remove the entire thing again. So those are the things where, at least in practice, many people are not very keen on taking a risk of having to change the cutter. Once you start, you would like to finish it off with one cutter. So those are the cases where you would definitely want to make sure that the case selection is appropriate. But clean cases, even PDR, where 27 gauge by itself gives a good advantage, those are good cases where you should go in, and you will find a lot more advantage than even 25 gauge. That was one thing. And then the other one is in terms of chorioretinectomy, at least in the periphery, I tend to avoid doing too much of chorioretinectomy, in the sense that if I have to put oil, I've seen suprachoroidal oil also going in, and there the retina may still remain attached to the choroid, but the choroid gets separated from the sclera, and it becomes difficult. I have been referred cases also how to deal with them. Once that happens, even if you remove the suprachoroidal oil, it just hangs there kind of. It's very difficult to push it back. But overall, I would say that the cases were very well managed, and normally what people will not do. I think those are very new, unique interventions that Dr. Sangeet Mittal has shown us.
Absolutely.
Mohit, can I add something?
Please, Divyansh.
So a very nice case management by Dr. Mittal is what we had seen. So the chorioretinectomy, like how we have seen Sir performing, is not using cutter, but using again just dense cautery, like 100% cautery. Keep doing it over the choroid, and it dissolves. It's as you see, the retina dissolves. It takes some time, and then it dissolves. We usually use 23 gauge, so that even the cautery is little larger. So we do not means what we have seen Sir doing, and what we have followed. Like as Sir told, smaller chorioretinectomies are okay, but larger ones have more complications. And we just use dense cautery, keep continuing over that area, and the choroid also gets dissolved over a period of time, rather than using cutter and then having a bleed from those areas. So that was our point.
Absolutely, point taken. Point taken, Divyansh. Absolutely. We're just going to dive straight into the third case, and I'm going to invite Dr. Apurva Ayachit, who is a consultant at the Joshi Eye Institute in from Hubli in Karnataka, and a dear friend. And she'll be talking to us on the ocular bushfire. And while she's uploading her screen, I just have one question, and that question was in the chat box and was also texted to me. And this is to Dr. Sangeet Mittal, sir. So, what would be your indication for doing a chorioretinectomy? Would you do it in every impacted foreign body case, or is there an indication that you would do it for or not do it for, sir?
I'll do it for an impacted foreign body case if it is in a posterior pole. for all cases, because these are the cases which tend to produce those membranes which will come onto the macula, and it's very difficult to remove them. So I've used this technique both as a prophylactic as well as a therapeutic option also, because sometimes earlier when we did not use these technique, these membranes used to come, we used to remove the membrane, and again it will grow from that exit wound and come out and come onto the macula. So I think for any case that has a potential to damage the macula, the ERM, I will prefer to do chorioretinectomy as a prophylactic procedure.
Thank you, sir. Thank you. Apurva, please. Thank you. Thank you for waiting. And Dr. Apurva Yache, please. Apurva, I think you're on mute. We can't hear you.
Yeah, now,
Yes.
sorry, that was a goof up. Yeah. So thank you for the opportunity. Can you hear me now?
Loud and clear.
Yes. So with 2020 and all its jinxing and its bad events, one of the worst things that happened was the Australian bushfire. And now I'm going to present a case which mimicked this quite a bit. So this was a 32-year-old healthy man. He presented to us with diminished vision in the right eye since 8 days. He didn't give any history of a fever, no flashes or floaters, no systemic illness. Right eye vision was 3 by 60 and the left was 6 by 9, and there was no anterior segment inflammation or vitreous cells. So this was his right eye. We can see that there is an area here superiorly, an extensive area of healing, and there are these fresh lesions at the margin of this healing. Also, there is this penumbra of fresh lesions surrounding an area of atrophy. The AF is very impressive because it shows up the fresh margins even better than the fundus photo. This is the OCT. We can see that the scan passing through the healed area has a collapse of the outer layers, and the scan passing through the active area has this kind of RP thickening and some expansion of the outer retinal layers over here. This is the left eye, and this is again the active margin, and which is kind of limiting the old healed areas. Left eye macula looked okay. There were some vitreous cells, however, and again in left eye in the active areas had this RP thickening. So this was a young man. He had healed lesions in the periphery already, and there was acute onset blurring of vision. So our differentials were serpiginous like chordopathy, probably tubercular. Serpiginous also was one of the differentials, and syphilitic plecoid chorioretinopathy was one differential which also seemed possible in this case. So we worked up for infectious causes of posterior uveitis. Admittedly, we just did a VDRL, we didn't do a TPHA. The rest of the investigations looked fine, as in the MON2 was negative, the chest X-ray was pristine. He was started on oral steroids 1 milligram per kg body weight. This was in February 2020. Unfortunately, the patient could come back only after a month because of the COVID scare. And right eye vision had now dropped to counting finger, and the left eye had dropped to 612. Now there were some anterior vitreous cells in the left eye. This is the right eye now. It has the margin of the activity has increased considerably, and there are these new lesions here, if you can see the cursor, which have cropped up like satellite lesions. So this is the montage. This is the right eye comparison from 1 month ago of the AF. And this, I didn't know about this. This is apparently the described cockade sign, which means that this lesion, which has 3 zones of a central hypoautofluorescence and a surrounding thin sliver of hyperauto, and then again a dark area, looks like a cockade that we wear in our conferences as badges. So this is a cockade, and this is the OCT line scan passing through the active area where there is an expanded choroidal lesion, which is suggestive of inflammation. There is a RP thickening overlying it. Again, there is the outer retinal layers that is showing hyperreflectivity. So this is an active area with backshadowing due to the double layering of the RP or the thickening of the RP. This is the left eye. Again, this cockade has graduated to become much worse than before. This is the left eye montage after a month. And this is a very nice OCT finding over an active area where there is, apart from the RP thickening, this sort of very obvious like expansion of the outer nuclear and the outer plexiform layer, and a sliver of this is not a sliver, but yeah, it is kind of a well seen hyporeflectivity in the outer retinal layers above the ellipsoid zone and the ELM. So here we see a comparison where these are the new lesions and here there was no lesion a month ago. Now we did an HRCT and we found that he had some areas of scarring and a fibrotic band in the lower lungs, lower lobe of the lung. So he was started on AKT4 under steroid cover in March 2020. Now again, there was lockdown imposed all over the country. So he returned after, I think, 6 weeks, or it was again a month later. Now his left eye was only 3/60. And this was despite anti-tubercular treatment. And now you can see that the lesions have really progressed far beyond the inferior arcade as well in the right eye. This is the montage of the right eye, which shows these active margins have come to the inferior fundus now, and we can see what the fire has left behind, all this kind of waste and charred retina, I should say, because all the outer layers are kind of enmeshed into each other and there is no differentiation whatsoever in the healed areas of the outer retinal layers. This is the left eye. Haze is considerable because of vitritis. And this is again considerable thinning in these areas, and there are some active areas in between. So this is a comparison of the 3 visits of the right eye, where this patient kind of looks like he has a fire that has started in his eye and is just engulfing his whole retina. And the AF also looks very much like that. And this is the left eye. So this is very similar to the Australian bushfire with these kind of pseudopodial margins. And now, honestly, I didn't know what this was. And when Mohit says I'm a dear friend, I completely agree, because I would love it that he calls me a friend, because it was because of a smart guy like him that I realized that there is something called relentless plecoid chorioretinitis, which I'd read only in the books, and I had no clue that I would see a case, because when I couldn't find anything on the infectious workup, I was just clueless about it. And that's when I called up my very smart friend, Dr. Mohit, and he told me that he probably, has seen some cases like this, and this could be the relentless variant of plecoid chorioretinopathy. And this time we went a step ahead just to rule out syphilis for good, and as expected, the TPHA was negative. We even did an FFA ICGA in this patient to kind of get more information about its characteristics. And sure enough, there were some window defects in the FA and a lot of hypofluorescent areas on the ICGA. So he was, despite his TPHA being negative, we wanted to do something for him. So we advised him to get treated like a neurosyphilis. But then he is lost to follow up again because of inter-district district travel restrictions. And the patient thinks there is some black magic done on him, and that's why he's losing vision in both his eyes. And although I don't agree with his diagnosis of black magic, I do agree that, this is really unfortunate that a young man, like a healthy young man, had to lose vision so drastically and so dramatically. And again, thanks Mohit for telling me what this is. And this was very interesting and quite. It gave me a lot of perspective about such cases, and I would really like to ask the panel how they would have managed this case, because uh, obviously we didn't do very well with this patient. So how would you have approached such a case, and what investigations would one order in the order of importance for such cases, and when would you start immunosuppression?
Thank you, Purva, for sharing that terrifically documented case, and for giving me undue credit. Thank you, and being honest enough to share a case. Everybody is very comfortable sharing success stories, I think, but as has been reiterated point in time and time again, I think we all learn from cases that, and because they tend to stick to our memory, that unfortunately don't do that well. So thank you for bringing this out. I would like to quickly go over to Dr. Ramandeep sir first for his comments on the case, and if he would have managed this case any differently.
Apurva, it's a nice case. Actually, it's all bad luck because of the COVID and so many things happening there. What we could have done. It's very easy to say that, but this is what we do in PGI. If the case would have presented to me, because I could see some cells in the eye. The moment I will see that this patient is not responding to the treatment, I would have done the diagnostic vitrectomy in the right eye. All right. So I would have gone for the diagnostic vitrectomy and taken the sample. I wanted to see here one thing. I wanted to see whether there is find any TB bug there. All right. If I am able to say that the gene expert something comes positive, then I would also like to know that is it a normal. I hope it's not a multi-drug resistance TB. That would be known from the samples. That I would have done. And then if this all would have come negative, I would have straight away put him on immunosuppression. All right, because my worry is the other eye. This is what could have, because I would have gone for the straight away for the diagnostic vitrectomy. Moment I have seen that is crossing the foveal center in the right eye.
So how sensitive is a diagnostic vitrectomy? Even in TB, we've seen literature from PGI that it's not very sensitive. So how much of a yield would
I
it
think
give?
immunosuppression we could have started earlier in this patient because his Montus is negative. So it's relatively safe.
Right.
Oh, yeah.
So what would be your take on Ozurdex in such a case?
So again,
Okay,
similar.
Dr. Raman.
Yeah. Ozurdex is not at all a bad idea. It is a doable thing, But if I have the facility of doing a PCR and diagnostic vitrectomy in this patient, I would have gone for that. But yes, in a COVID times where the facilities are not available, and because it's a bilateral disease, see that's my major worry. Is something happening to the both eyes?
Great, sir.
So how sensitive is a diagnostic vitrectomy for TB also? I don't know if my question was heard. There is data.
It's an adjunct.
Sir, Raman sir, we lost you for the last 20 seconds, sir.
I'm so sorry.
Sorry, आप repeat कर देंगे. Sorry,
I was just saying that it's a bilateral disease. Ozurdex is not going to take care of the both. If you give it in the one eye, you can give it in the other eye also. It'll just buying you time for you. But you have to, on the definite side, you have to treat the patient with the immunosuppression or the specific, drugs if something comes out from the.
I think we lost her a bit. If I'm gonna jump in here, sorry, and for want of time. So again, Apurva, I'm gonna take your answer that question. How sensitive is vitrectomy? Sorry, sir. Again, we lost you for about 10-15 seconds.
Yeah.
So again, how sensitive is vitrectomy for diagnosing TB uveitis? That's a broad question. It depends on what indication of uveitis you are planning the diagnostic vitrectomy for. So if you're doing it, let's say for predominantly choroidal lesions with hardly any clinically detectable vitreous cells, of course your sensitivity is going to be lower. If you're doing it, let's say for a burnt out, for sequelae of occlusive vasculitis, and most of what you're sending is old heme, or kind of. So of course, the chances of you making a diagnosis there are lower. A lot of other cases, we generally don't operate patients with choroidal granulomas, big ones. We hardly ever operate patients with choroidal abscesses, in which TB might be the thing. So those are the cases which will have a lot of multibacillary disease. The load of the bug will be high. Diagnostic vitrectomy is going to be a big help. As sir's pointing out, in this patient, because your OCT also showed there were a lot of cells even in the posterior vitreous, and also on when the left eye got involved. When you actually came to the brush fire, I think towards the end of your presentation, the media haze was, I think, telltale even in the fundus photo, that there was considerable intraocular inflammation for us to try and tap. It's not a guarantee or a given that would have yielded anything, but having done it earlier on, our threshold for doing diagnostics in cases which are atypical, don't fit the bill, is lower. Primarily because once you have ruled out, you can very confidently rule out masquerades, which is not the which was not one of
Yeah,
the
yeah.
DDs here, but you can rule out masquerades, and you can rule out viruses, HSV, VZV, CMV, toxo, and to a large extent TB. If
Yeah.
that's ruled out, as sir said, it'll give you 10 times more confidence and conviction to start the
To
patient
start
on single or
immunosuppression.
double immunosuppression and trying to save the fellow eye. And I think also, I think here for this patient, because I'd seen this earlier, I'm just taking this opportunity to take 1 more minute on this. So I think pattern recognition is very important. The
Yeah.
brush fire, I think that video that you showed was super, because that kind of drives home the point, because it kind of spreads like that, and the area which is actually gone, that'll either heal with pigmentation or not. In your cases, it did not
It
heal with
didn't.
exuberant pigmentation, but they'll be like a leading edge, which will look a lot more yellower, which will look elevated as compared to the area which is actually gone. And you could have multifocal areas of it. If you
Yeah.
were to do optos, you could have islands, so you can have multifocal areas with lots of focality within it. And that's why when they describe the relentless plecoid variety, they said you can have up to 50, more than 50 lesions
50
in one eye,
lesions.
which might coalesce later on. And quite frankly, if you don't target it very early, very aggressively with steroids, high dose along with immunosuppression, and that too they've shown that, and that's why they coined the term relentless plecoid, because it's relentless even on steroids. The moment you start to taper, it'll come back, it'll progress. It sometimes it might not respond just to steroids. You might need to add intraocular steroids. People have added triamcinolone, just case reports to it. People have gone as far as going on to saying that we give straight away we go on to TNF alpha blockers, and that's what takes care of it. So typically things like these which don't these will, so if you recognize the pattern, I think it's very important to start immunosuppression early and tell the patient you might need a second immunosuppressive agent, akin to what you might do when you see a Behçet's patient. So this is
Right.
one of those varieties of non-infectious posterior uveitis. Luckily for us, not that common. Serpigen is one of the variants of serpiginous choroiditis, which is multifocal, mimics intraocular infection, can have exuberant vitreous involvement, has the chances of involving the fovea, because again it'll just keep on going because you're not treating it right. And every time you look at the patient, you feel it's infective, you keep treating for infection and kind of hold your hand as far as the adequate double immunosuppression is concerned. It might be needed sometimes. And once you do that, these people do very well. You could also treat with intravitreal triamcinolone or methotrexate, or but they need more than one immunosuppressive agent and hit it hard early. And people have, as I said, recommended TNF alpha blockers for it.
Mm.
So that would be my
Can
take on.
I can I add
Sir,
something here as a non-uveitis person?
sir.
Uh, yeah. So Apurva, a very nice case. I mean, whenever we get such cases, I mean, you did the right thing. After applying your mind, keeping open your differential diagnosis, taking other opinions, and that's what I did. As soon as I got your case yesterday, I immediately passed it on to my colleagues here, Mudit Tyagi and Soumya Basu. Before I come to their perspective, what typically as soon as I saw this case, I mean, apart from tuberculosis, I felt that syphilis was probably also high on my differentials.
Mm.
I don't know. I mean, second guessing is always easier, But I would always consider that in our part of the world nowadays we are diagnosing more and more syphilis cases also. So, and VDRL, and whenever I'm suspecting a syphilitic chorioretinitis, I go straight away for TPHA rather than just VDRL. We don't have to go into the details of why we are doing that.
Right.
But then, based on both Soumya Basu's and Mudit's, they just glanced through briefly when I shared it with them. Both of them felt that tubercular etiology is probably higher up than syphilis in this case for various reasons. I had they have made some slides also. I could, but I think due to lack of time, I may not be going into all the details. But they are shown what are the differences putting side by side of a syphilitic versus a tubercular. What is the autofluorescence difference? The sharp edge of the autofluorescence, which you are seeing with a nice ring around the pigmentation on autofluorescence, that typically goes in favor of a tubercular or a non-syphilitic etiology. But still, TPHA, even if you are suspecting high, they have had an experience where they got it from another lab, and that came out to be positive for TPHA, and they gave penicillin, and the patient improved very well. Now, before we go on to immunosuppressants, we must make sure that we have ruled out tuberculosis or even syphilis to the extent that we can do. In that context, we have discussed about PCR on a vitreous sample. I would go even further to the extent of taking a chorioretinal biopsy in these cases. If we have a very high suspicion of, let's say, tuberculosis, if the yield of vitreous is going to be less, as Mohit mentioned, that it depends on what kind of presentation they have. But yes, in such cases, if we really want to say that now this is non-infectious, I will go straight to immunosuppression, then a chorioretinal biopsy is worth doing it, and say that okay, I have done everything possible to rule out, and then going straight for high-end immunosuppression in this case. But overall, I would say that this is a very nice case where we have to take opinions, and opinions first time may not be right, the second time opinion may come something different, a third opinion may be coming. What we are seeing is not uncommon in uveitis in these kind of cases. But absolutely agree with this approach of, unfortunately patient due to COVID could not come frequently, but we would have
Exactly.
gone that way, what you have done so far.
Thank you, sir.
Thank you, sir, for the comments. We're quickly going to dive into the fourth case, and may I request my dear friend, Dr. Ramanuj Samanta, to please share his slides. Ramanuj is assistant professor at the AIMS at Rishikesh, and is an excellent person to boot. And I've known him for many years now, and he'll be sharing two cases. I think three cases with submacular cysticercosis. Ramanuj, please.
Thank you, sir. Am I audible?
Loud and clear, Ramanuj, please.
Yeah. So at the outset, I would like to thank my mentors and colleagues at PGI for including me in this webinar. I will be talking about few cases of subretinal cysticercosis. So my first patient is a 55-year-old male who presented with gradually progressive decreased vision in the left eye for last couple of weeks and presented with the best corrected visual acuity of 3/60. On examination, there was presence of a live undulating translucent cyst in the submacular region. And we can see in the fundus picture that there was also presence of 360-degree RPE changes around the subretinal cyst. So the corresponding OCT showed a presence of hyporeflective lesion with surrounding small area of neurosensory detachment. And the autofluorescence also showed 360-degree RPE changes. The diagnosis was also confirmed on ocular ultrasound. So the patient was explained about the need of the surgery and consent for surgery was obtained. So we went ahead with the 25 gauge transconjunctival sutureless vitrectomy. First of all, triamcinolone acetonide was injected and gentle hyaloid removal was done, taking care not to cause any inadvertent rupture of the subretinal cyst so as to avoid any dire complications. And after removing the hyaloid meticulously, peripheral skirts of vitreous was removed thoroughly. And then I made a superior retinotomy. Here I encountered one problem. While I was trying to make a retinotomy through the superior portion, I could not get access because the patient had a very deep-seated eye. So I shifted to the temporal side as we do in temporal phaco and shifted the infusion cannula superonasally. And with the help of 25 gauge active suction, silicon tip assisted suction assisted, the cyst was exteriorized into the vitreous cavity. After exteriorizing it into the vitreous cavity, it was rapidly engulfed in the vitreous cavity with the help of the cutter, and which was followed by fluidier exchange, and the patient silicone oil tamponade was done because the patient belonged to a high altitude region. So following that, the patient, as the patient we had seen preoperatively also had some amount of RPE changes. The patient's visual acuity did not improve much and had some amount of subretinal fibrosis and improved the visual acuity to the extent of 3/60. So my next patient is a 35-year-old lady who presented with gradual decreased vision in left eye for last couple of weeks, but she also had a coexistent unrelated acute mastoiditis. So at the time of presentation, she had visual acuity of 6/24. We can see that the presence of a subretinal lesion, and this lesion was confirmed as cystosarcosis on ocular ultrasound. But due to mastoiditis, rapid ENT clearance could not be obtained. But after 4 weeks, when she presented, the cyst has increased in size, which we can see in the fundus photo and OCT, and we convinced the patient that it's high time you get operated. But unfortunately, we could not convince her, and though he continued to follow up and came back after 6 weeks, her visual acuity had declined further to the extent of 5/60. So we explained everything, and we also provided the option of free surgery at a government setup like us, but unfortunately she was lost to follow up. And when she came back after 6 months, so we can see that there is presence of complete narrow funnel retinal detachment and presence of neovascular glaucoma. Her vision has dropped to the no light perception and pressure of intraocular pressure of 40 millimeter of mercury. So unfortunately, we could not salvage vision in this patient. And my third patient was a 10-year-old female child who presented with diminished vision in the right eye for 6 months. And she also complained of headache and intermittent vomiting for last 3 weeks. So he was treated as posterior uveitis elsewhere with topical steroids, but not of much benefit. At time of presentation to us, her visual acuity was light perception in right eye and left eye was normal, 20/20. So on examination, we could see there was presence of disc edema, peripapillary tortuous vessels, total retinal detachment, and temporal few subretinal bands, and inferonasally of whitish lesion, subretinal lesion, which was suspicious of something. And in the left eye, we saw disc edema. Other than that, the left eye was normal. So when we did ultrasound, we could locate the, again, subretinal cystosarcosis with a scolex. And after doing a brain MRI, we could see multiple neurocystosarcous lesions at various stages. So at this point of time, we offered her surgery under nil visual prognosis, but she opted out of surgery and she was given systemic steroids for symptomatic relief and was under neurologist's care. So my question to panelists in the sense is that removal of subretinal cystosarcosis, what is their take in whether they would like to remove in toto versus engulfing in the vitreous cavity? Because literature shows even it is removed rapidly within the vitreous cavity due to good fluidics in the modern vitreoretinal equipment, there is not much of problem. But does engulfing in vitreous cavity, what is done in that case, could have increased the propensity for subretinal fibrosis? But interestingly, we have seen that in our patient also preoperatively, the patient had significant RPE changes. And third, any experience of temporal pars plana approach in deep-seated eyes like we do in temporal phaco or like that. And fourth, aspiration of cyst by cutter versus active silicon tip assisted suction. What is the opinion of House? And what will be the preferred retinotomy location? Because when we try to do it, when there is limited amount of neurosensory detachment, so if it is retinotomy is located away from this, there is difficulty in accessing the cyst. So what should be the preferred retinotomy location? And in no light perception eyes, should they be operated to prevent complications like neovascular glaucoma? So what is their opinion on that?
Thank you, Ramanuj. I think thank you for sticking to time and excellently presenting three cases. I think with varied presentations and outcomes. But I think your main points you would ask them very well. I'll straight away go to Sangeet Mittal sir first for his comments. So if you would like to give your tips on 2-3 points that Ramanuj raised, whether we can look at a temporal approach in these eyes if the eye is deep set, and for submacular cysticercus, which is thankfully not the commonest thing, where would you prefer to make the retinotomy, and your preferred way to either allow the cyst to come out or to manually aspirate or use the cutter? What would be your surgical tips, sir?
Yeah. First thing is like engulfing the cyst inside the eye. I think now it has become a standard approach. We don't enlarge the sclerotomy and bring out the cyst in toto. We generally just keep the cutter close to the cyst and just eat it up. Within a matter of seconds, it just goes inside. And second thing about the temporal approach, I think it's very well since the time I have started using 27 gauge vitrectomy, most of my left eyes I am operating temporally only. And even if you see some videos also, you will notice that the approach is there, and it works well. Initially, you do have some difficulty while you are shifting to a temporal approach. The way you are sitting in front of the patient, your legs may hamper your movements. But once you get over that phase, I think temporal approach is quite good. Especially in some patients, it is indicated. And next, coming to the next question was about the instrumentation to remove the cyst. Both the cutter, both the suction and the forceps. There earlier when we used to do vitrectomy, I think Dr. Raman may also remember, we had the special instruments, subretinal instruments. We had a bent forceps, which was 30 gauge. And we used to, I had used that forceps also while removing this cyst. It just comes out like a forceps delivery. You just need to make a very tiny sclerotomy, retinotomy. You don't need an extensive retinotomy in these cases, just a tiny retinotomy, and just hold it with the forceps and it will come out very nicely, just like a forceps delivery of the baby. And it's just as you see in his case also, using a vacuum, just like a vacuum delivery of the baby. It comes out of a very small opening, the whole big cyst comes out. And the last, the positioning of the retinotomy, I think depends on which hand you are comfortable with. If you are right-handed, so just go I think towards so that you can move your instruments in line with the cyst. You can place your retinotomy like that. If you are left-handed, you have to use the other side of the to make the retinotomy. I think that answers most of his questions. I'd like to ask Raman and Dr. Raja also to elaborate on these.
Dr. Raja, please, and then I'll go to Raman, sir.
Yeah, so very nice presentations, Dr. Raman. What, if you ask my personal experience, fortunately and unfortunately, in the last 10 years, I have not had any encounter with cysticercosis patients. But going by what we know now is that you don't have to bring them out in toto. You can definitely remove them in the vitreous cavity. But I would be worried about definitely leaving behind anything subretinal. You definitely won't want to rupture it subretinal. So overall, I think removing the vitreous itself is probably a good idea. In terms of where you would like to make the retinotomy, definitely where you are comfortable, as Dr. Sangeet Mittal pointed out, that you don't want to make it on the inferior side because then your hands won't reach, or definitely onto the wrong hand side. But whichever approach is more comfortable, you can make it. But in terms of the retinotomy, I definitely want to be slightly more generous than thinking about worrying about making a large opening. It's about trying to remove it in an easier fashion rather than having a chance of rupturing subretinally. Then treating that, washing them, you will have to more spend time over there. So overall, this is my take, that you can definitely remove the cyst within the vitreous cavity.
Can I make a brief comment, sir?
Sure, Ramanuj, please.
Yes, the problem was if some cyst has a limited amount of neurosensory detachment around the cyst, I think then there is a problem of removing, because doing retinotomy away from the cyst will cause bending of the soft tip. And again, what I did a retinotomy a bit away, and then I injected subretinal some kind of BSS so that it creates some kind of space. Then I tried to access. So if it kind of have some kind of neurosensory detachment, preoperative OCT will help to locate it, which site has more kind of neurosensory detachment. Probably intraoperative OCT will also help, but most of the persons will not have access to that. So I think,
Yeah, so if there is more fluid towards the macular side, obviously you will have to do it on some other portion and create some amount of RD, so that you can get access and easily remove it. So that's not an issue. But for me, as I said, I haven't seen, I see more of subretinal PFCL with that kind of OCT than subretinal cysticercosis. But then yes, your point is right, that wherever there is fluid, you try to go there, you will have space. If not, you have to create a retinal detachment, remove it.
Absolutely. Raman, sir, final comments from you, and then we'll go to the next case.
I think I've most of the things has been answered. People have tried moving the cysticercosis with the PFCL, but if there is a fibrosis around it, it will not move actually. But if there is something, the fibrosis is not there, you can always try PFCL and just moving it away. But yes, Ravanu, the main thing is you don't want to make a retinotomy over it and rupture this thing, but whatever you're doing is creating RD and trying to take it away from the posterior pole is wonderful idea. Yeah, great case.
Terrific work, Ramanuj. I think posterior pole induction of RD was, I think, the point that you made right. If the fluid's not right, if the fluid's not there, you induce an RD so that you have more space to manipulate, and your instrument is not hitting either the choroid or that. I think great point, Ramanuj. And because we're running a little late, I'd like to go to the fifth presentation, please. And can I request Dr. Priya Bajgai to share her screen, please? Priya is also a dear friend, and she adds international flavor to our webinar this morning. And she's actually from Nepal. She's an assistant professor at the Nepal Eye Hospital from Kathmandu, and she has a very well documented, terrific case to present, which I'm pretty sure a lot of us would not have seen. And really looking forward to your case, Priya, please.
Thank you so much, Dr. Mohit, and thank you for this opportunity. So moving on to my case, so I'll be presenting a case of, am I audible? I'm sorry, I didn't ask that in the beginning.
Loud and clear, Priya,
yeah, okay, thank you. So this is a case of a bilateral ciliopyramidal effusion. So 58 years old female, she came with complaints of painless decreased vision in both the eyes for the last 5 months, and there was no history of any other ocular history of trauma or surgery or use of any kind of medications in the past. So right eye vision was 160 and the left eye was just perception of light when she came. So she had a pressure of 32 and 38, and on anterior segment examination, I'll be showing you, she had a clear cornea with a shallow AC both centrally and at the periphery, and 360 degrees of prominent episcleral vessels like we can see in both the eyes. And we could see there was a choroidal elevation right behind the lens, and on further evaluation, we can see that there is a 360 degrees of elevation with the cup disc ratio. The disc was clear, so it was 0.2 to 0.9 of cupping in the right eye, and similarly in the left eye also there was 360 degrees of elevation, and it was 0.5 to 0.6 with inferior notching, as we can see here. So the ultrasonography confirmed our diagnosis of ciliopyramidal effusion, and at this point the axial length was normal in both the eyes. As we can see, it's 22 in the right eye and 21 in the left eye. We do not have UVM, so we could not see for any mass lesion behind the ciliary body area at this point. So we basically wanted to look for the cause. So the common causes are like the arteriovenous fistulas, ciliary body tumor, it could be metastasis, it could be a cause, simple case of nanophthalmos type 2, or it could be posterior scleritis. So on further evaluation, so this was done by our resident, we smartly checked for the systemic workup. So She gave a history of 20 years of cough, and she had history of exertional dyspnea, palpitations, and chest tightness. She was a heavy smoker with 2 to 3 packs per week for the last 40 years, history of weight loss, and some kind of abdominal surgery, but the details were not available. And she had never been seen by a physician yet, so she was not on any kind of systemic medications either. On general examination, we could see she had clubbing, pedal edema, and on chest examination, there was hyperresonance and percussion of the chest, all the lung fields. There was auscultation. We could see basal crepitations in the bilateral lower lung fields, and on abdominal examination, we could see a firm mass just below the umbilicus, but there was no lymphadenopathy that we could palpate. So from our side, we started on brimonidine, dorzolamide, bimatoprost, and steroid in view of the effusion, but we did not give her any oral medication because the acid dizolamide is seen to be causing more of effusion in certain cases. So immediately with this, we sent the patient to a physician because of her chest condition, and also planning to start on oral steroids for effusion from our side. So the basic labs were within normal limit. The CBCs were normal except for a slightly raised hemoglobin and hematocrit. And the ultrasonography showed that it was just a hysterectomy stump that we could palpate. Otherwise, there was no other abnormality seen in the ultrasound abdomen. So the MRI picture, we can see that there is effusion. You can see the separation is suggestive of effusion, and no kind of any ciliary body mass was noted. And in this picture, we can see that the superior ophthalmic vein is of normal caliber, and so that the carotid cavernous fistula was ruled out and the mass lesion was ruled out. And on X-ray, we can see it was a prominent pulmonary arterial trunk, mild cardiomegaly, and emphysematous changes in both the lungs. So the internal, after consulting with the internal medicine, she was further seen by a pulmonologist who advised for a CCT chest. And here we can see this is an enlarged pulmonary arterial trunk as compared to the aorta. So the ratio we can see here is more than 1. So the diameter is normal is 25, but in our case it's seen to be 38.4, and this artery is to pulmonary aorta ratio. If it's more than 1, that implies that the arterial pressure is more than 25 of the pulmonary vessels. The normal is taken to be 20. So, and the other features are suggestive of collapse of the lung, which is more towards COPD. Since she was a smoker, so the diagnosis of COPD with pulmonary arterial hypertension was given. So our effusion was attributable to pulmonary hypertension, which falls under group 3 because it's associated with the COPD. So we advised for the stoppage of smoking immediately because the smoking itself is seen to cause increase in the choroidal vessels, and pulmonary control, arterial hypertension control. It was planned by the pulmonologist. They've further planned for echo and ECG, but because of the COVID, she's not been able to start all the medicines as yet. We started on oral steroids at a tapering dose and continued all the anti-glaucoma medications. So on further follow-up, you can see the right eye effusion has completely disappeared. The left eye was still persisting, involving the foveal region. The pressures were slightly normalized now, 21 and 22 and 21. The right eye is still high for a cup disc ratio. So we further again evaluated. We can see after a month that the prominence is still there. The episcleral vessel prominence has not gone away. And there is blood in the Schlemm's canal now that we could do a good conioscopy. And the left eye on the last visit, we can see that the fovea is spared, but the effusion is still persisting temporarily. And this on autofluorescence, we can see all the sequelae of effusion, like lipofuscin deposition and RP alterations, further seen well defined in the ADI-OCT. The choroidal thickness is more or less normal. In the left eye, we can see retinal folds and RP clumpings. These have all been described with the effusion. So we could see these features still persisting in the left eye. And the effusion part is still there, we can see here, but it's sparing the fovea at this region of time. So the vision has improved. We can see it's now 6/12 in both the eyes. However, the IOP is still on the 20s. So this is a few cases we've seen that the pulmonary hypertension, especially the type 1, it's not been seen with the group 3, which is COPD. So type 1, it has been associated with pulmonary effusion. So I'd like to ask the following questions. How common is the association, especially the group 3? It's seen in group 1, but I could not find in the literature about the group 3. And can there be other associated factors, like she had a history of chronic smoking also, probably that also led to further increase in the choroidal thickness and further constriction. So probably could there be other ocular factors in her? And systemic workup, how extensive can you go for it? Because we, luckily, our resident did a very nice job, but how important is it in every case to do all the workup of effusion? And how long should we continue the oral steroids for? Because we're planning for glaucoma surgery in a right eye, and there is always a risk of effusion coming back. So how would you managed. So I could not have solved this case without the help of all my colleagues, resident, internal medicine friends, and radiologists. Thank you.
Great case, Priya. I think super, great job, great job.
Thank you.
I'm gonna throw that first to Raman sir. Priya, if you could please stop sharing your slide.
Yeah, sorry.
So I think the main is again the eye is the window to human body, but the port wine colored episcleral vessels, I would first jump to that actually. Okay, if you see them bilaterally, this is our classic teaching that if you see them bilaterally, so they cannot be more than 7-8 etiologies. One of them is the fistulas there, so you can rule out with the trauma, and then you have any venous obstruction. All right. So and you rightly said tumors, Sturge Weber's or tau. So once I look at these episcleral port wine colored episcleral veins, I will definitely look up for the systems, and this is what your resident did nicely in this patient. And it has been nicely reported in pulmonary hypertension because it does causes venous obstruction. So this is again a diagnosis made by just a clinical, this thing. Otherwise, we could have taken this case as a fusion syndrome and run battery of investigation unnecessarily. So I think the clinical acumen, the history, the systemic evaluation, and we should not rely. If you don't have residents, all right, but sitting in a clinic anywhere in the world, we should keep the suspicion very high in these patients. This is how it's a great case actually. Rather chances of fusion, yes, they are there again. Whatever you have to do in future is take care of our systems. And if you can, there's a controversy over the role of the steroids. One of the Shields group is very fond of the steroids, but some people don't give steroids. Again, those are controversial. But again, the systemic management is the most important. If you take care of the systems there, everything will be taken care of. Yeah.
Thank you, sir. Sangeet sir, your comments, please.
I think I agree with, although this is not, I don't know, I have not seen this kind of a case beforehand. But I think what Raman had said, a strong suspicion of clinical things, and as she had done very nicely, she has worked up the case. But one thing I would like to ask the other panelists also is the use of dermatoprost in these cases. Whether we should use dermatoprost when this kind of ciliocoroidal effusions are present or not. I don't know. I think I would like to stop dermatoprost in this case.
So, Dr. Sangeet, you're right. You have to rule out the other systemic drugs. The one the psychiatrist gave you have to rule out, take the whole history, whatever causes the ciliocoroidal. But I will first look at the episcleral vessels. Because if I see the port wine episcleral vessels, I will not go into the drugs history also. So probably I think, but it is important to take the history of drugs. Whether you are on the which psychiatric drug is there, Mohit? I'm forgetting the name. This is clopramide. Yeah,
Topiramide, sir.
Topiramide, yeah.
Actually, any kind of sulfa drug can cause. Topiramide is a sulfa-containing. Hydrochlorothiazide can also cause.
Diamox, absolutely.
Diamox can also cause. So, I mean, all these become important in terms of history, and I think overall the case has been very well managed. So, I mean, whenever you have these cases, very difficult to say. I mean, as Ramandeep has pointed out, that steroids may or may not be beneficial, but overall, if you ever have to, in the sense the fluid doesn't go away, choroidals don't go away, and you want to drain them, then there comes a problem that should you be waiting for should you be starting steroids pre-op, or do you give concomitantly when you are giving these after the surgery? Do you want to give steroids? Typically, I do give systemic steroids in these patients. Even if you have to drain these choroidals, at that time also I give oral steroids in these patients. But overall, I think very nicely managed case. I don't know what was the pulmonary artery pressure in this. You mentioned about the artery diameter, but nowadays we can also measure the pulmonary artery pressure. That can also tell us actually whether it was how much was it elevated in this case, and that may give also a better indication how much it's correlated with this choroidal effusion.
Yes, sir. So she has been planned for echocardiography, which will help further to see exactly how much is the pressure like. But now, because of the COVID, all the pulmonologists, they're also busy, so it's very difficult to get an appointment. But roughly by CCT also, like I showed you the ratio, like the pulmonary arteries to aorta, if it's more than 1, it's more than 25. But still 25, 30, 30, 40, it's not enough to cause effusion. If you see at the literature, then the primary pulmonary hypertension where it's been reported, it's supposed to be, it's seen to be as high as 70. So only after echocardiography, we can definitely say how much pressure it was and if it was the only factor responsible, or it could be other factors also along
Yeah,
with
so
pulmonary
because
hypertension.
if it's very high, as you said, about 70, I can still understand, because looking at the lungs, I mean, yes, there was some amount of emphysema or cardiomegaly, but I don't know whether that by itself was so severe to have caused this problem, whether there was any additional thing we should
Additional
have
factor,
looked
yes,
out.
yes.
But
Simar, you were asking something. Just there are 5 groups of pulmonary hypertension. So one is the primary. That group 1 is the one which is associated with hereditary. These are the ones where all the reports are with type 1. Type 2 is with the left heart failure, and type 3 is the ones which are related with the chest, like the lungs, COPD, and also mine was group 3, which is the secondary causes. It's not reported to cause because the pressures, like they said, it's not enough to cause cilicoidal diffusion as such.
can I just make one quick comment?
Okay.
Yeah, so I think I've seen a similar case, probably not with the emphysema. It was a bilateral uveal effusion with pulmonary hypertension. This was during my fellowship, and I was being managed by Dr. Ligam Gopal sir. So despite of having systemic control and everything, the fusions were still not going on. So we had to eventually go ahead with a partial sclerectomy, decompressing the vortex, and then eventually the patient improved.
I think great. Thank you, Veer, for adding that. I just have two small comments to make, and then we'll move forward. I know there are a few questions there. I'll try and take them as and when, try and squeeze a couple of questions of the chat boxes in. I think 2 points. I think other than the excellent points raised by the panelists, I think one should never be shy of ask if this was a female who eventually turned out to have COPD because she was a smoker for many years. Please don't have the taboo to ask the female gender, whether they smoke or not, if you feel it's clinically relevant to ask. Lots of times, okay, nahi ji, ye to, she's a lady. How can we ask? I think that is something that is that should not be stopping anyone. If that is because that was a very pertinent and important history which led to the COPD being discovered, and all of that. And I think the second thing, I disagree, Pash, just from one small point in your presentation, Priya, the axial orbital imaging that you showed, both sides superior ophthalmic veins are actually dilated, and you would intuitively think that they should be as well, because this is a case of bilateral increased episcleral venous pressure because of the pressure coming from the pulmonary arteries. You can't get that amount of venous congestive changes in the eye in the form of AC shallowing, ciliocoroidal effusions, the arterialization of the conjunctival vessels without your superior ophthalmic vein being like that, because that's what's transmitting all of that back there. And in fact, your axial imaging, your neuroimaging is showing both superior ophthalmic veins. So anytime I think you can see both superior ophthalmic veins dilated, you need to look beyond the eye. It's not an ocular problem. It's an extraocular problem causing back pressure, causing the veins to go up, and the pressure changes in the eye. That was just my 2 cents worth of whatever points I could add. With that, I'm going to again request Sangeet Mittal sir to please share his screen once again, and we'll see his second round of videos using 27 gauge on nucleus drop. And thank you, Priya, for that excellent case. Thank you. Thank you.
Thank you, Mohit, again. I'll just share my screen now. Is the screen visible?
It is, sir.
It is. So I'll just another myth is that 27 gauge vitrectomy, along with it, you can't do a nucleus drop case. So just going to show some cases of nucleus drop. So nucleus drop up to grade 2 can be managed with the cutter itself. You don't need to do anything else. You see, I'm doing a 27 gauge vitrectomy in this patient. Actually, this was my first case of nucleus drop, which I managed by the 27 gauge, and the doctor had told me it was only a retained lens matter only, there is no nucleus. But to my surprise, when I entered the eye, there was nucleus also. So first of all, I remove the lens matter, and then similarly, as we do in your bigger gauge cases, similarly, just caught hold of the nucleus and then just crushing the nucleus with the light pipe. You can do remove this also. And with the I'm using a very high section and a very high cut rate in these patients. I think the high cut rate now available with the cutters also had to break up this nucleus. It just acts like a hammer onto the nucleus, and slowly all this lens matter was removed. And later on, as I told you, you don't need to actually seal these wounds with air or something like that, which can disturb the lens, which is already in a compromised, in the intraocular lens, which is already in a compromised situation, like either it is in the sulcus or something like that. So after this, you just complete your vitrectomy. It just induce the PVD and complete the vitrectomy. So again, sometimes even a hard nucleus you may be encountering during your vitrectomy cases. And this is one of such cases. We did a 27 gauge vitrectomy and we realized that the nucleus was very hard. And once we have, what we can do is I prefer to do a 20 gauge sutureless this incision, a beveled incision about 1 millimeter in size, and then put the plug in there to create a track. And then you can introduce your fragmatome. And even with the 27 gauge infusion, you can actually, when you're working very close to the nucleus, once you hold it, it does not cause any pressure changes in the eye. You can see even when small pits are left, you can easily remove with the fragmatome also. And this 20 gauge sclerotomy, you can leave sutureless again. So these were the two cases I wanted to show of nucleus drop being managed with the 27 gauge vitrectomy only. So I again pass on to you.
Thank you, sir. Raman sir, can we have a quick discussion on these, please? A few comments, and then we'll dive straight into the next case.
I think
can I request Kalpita to be ready to share her screen, please.
These are excellent videos, especially the second one, but they should come with the caveat that not to be tried by the non-experienced surgeons. Once you are experienced enough and have God's hand, like Dr. Sangeet's hand, you can try these. But I still feel 80 Vicryl is available. And even if somebody feels that there is a leakage or there is a risk of hypotony in one-eyed patients, in any patient you feel that post-op, because my greatest worry is post-op hypotony in these patients and choroidals. So I will not shy of putting a 80 Vicryl in these patients. Yeah, this is all I have to add.
Dr. Kalpita?
Am I audible?
You are. I'd like to just briefly introduce Dr. Kalpita, who's again, ex-alumni from PGI and is presently associate consultant at the Shankar Netralaya, Kolkata, and does vitro-retina as well as ocular oncology. And let's see what she has to tell us in a great masquerade case. Kalpita, please.
Thank you, Dr. Mohit, and thank you for the opportunity, Dr. Raman sir, Dr. Mohit, and Simar. My case is a 51-year-old gentleman who presented with decrease of vision in the right eye for last 5 months. He was a known diabetic for the last 20 years, which was under well control. And before presentation to us, he was diagnosed as PCV elsewhere and received 4 injections of anti-VEGF in the right eye. This is the fundus photograph of the patient. On presentation, his best corrected visual acuity in the right eye was 618 and 24, and the left eye was 66 and 6. Anterior segment was within normal limit with quite AC, and on slit lamp examination, there was no anterior vitreous phase cells also. So vitreous shows that he had asteroid hallucis in both the eyes, and in the fundus photo, we can see the media was hazy due to, and we can see under there was some amount of pre-retinal heme in the right eye, and details of the macula was not very well visible. Right eye, left eye also had some RP defect just inferior to the disc. There were no other significant findings. So keeping in mind the diagnosis elsewhere as PCV, we advised FFA ICG for the patient, but due to presence of there was presence of blocked fluorescence all through the phases of the FFA ICG in the right eye. So the details of macula was obscured, but in the OCT we can see there was presence of hemorrhagic PED corresponding to the area of the pre-retinal hemorrhage with presence of double membrane sign, which was suggestive of IPCV. And with the peripheral examination, he had some NPDR changes also. In the left eye, he had this inferior to the disc, he had presence of one small drusenoid PED. There were no other significant findings. OCT angiography of the right eye showed presence of neovascular membrane corresponding to the area of the PED. In the left eye, however, there was no flow in the area of the lesion. So we kept the provisional diagnosis as PCV with BVN under the macula with breakthrough vitreous hemorrhage right eye, and advised one injection of anti-VEGF in the right eye. We decided to observe the left eye for that time. Subsequent follow-up, we could see that the size of the PED was reduced to some extent and vitreous hemorrhage was clearing. However, due to the fluctuating nature of the vitreous hemorrhage, his vision ranged from 618 to 69 in subsequent 4 visits. After that, patient was lost to follow-up for 6 months. So after 6 months, when he comes back to us, he brings all the papers where he was diagnosed with ileocecal lymphoma and received 6 cycles of chemotherapy. And now when we do the fundus photography, we see, and clinically also, we could see that the vitreous hemorrhage has completely cleared, and we can see a well-demarcated area of RPE atrophy in the right eye, as well as development of a new area of RPE atrophy along the inferotemporal arcade, which was in autofluorescence, we can see the area of RPE atrophy more prominent. So we advised FFA ICG in this visit also, and which showed as a typical pattern of leopard skin appearance corresponding to the area of the RP atrophy, which was more prominent in the late phase. However, if we see carefully at the macula, there was a presence of a choroidal neovascular membrane also, and presence of, we can see the presence of a very big network of BVN at the macula in ICG in the late phase. At the same time, patient developed PVR changes in the PDR changes in the right eye also. However, left eye, he maintained the NPDR changes with no other significant findings. So when we do the OCT angiography through the lesion, we could see the well-demarcated mature vessels suggestive of a most probably a scarred choroidal neovascular membrane. Left eye, we could not make out any neovascular changes. So now the dilemma was, what is the diagnosis for this patient? Is it PCV? Because we kept the diagnosis of PCV because the reason of the breakthrough vitreous hemorrhage and the characteristics membrane seen in OCT or OCTA at the macula, which was supported by FFA ICG also, and absence of any vitritis. The diagnosis of lymphoma we kept in mind because of the shape of the PED, because the shape of the PED was little irregular when we looked the scans respectively, and there was elevation of the RP was also a little irregular. There was no presence of fluid throughout his all follow-ups what we had, and he had a very good response to the chemotherapy. I forgot to mention that time his vision came to 6/9 and 6. And we could see the characteristic fluorescence and FFA findings post-chemotherapy. So this patient completed 6 cycles of chemotherapy, and after completion of 6 cycles of chemotherapy, there were no active or residual lesions in the PET CT. But the membrane under the fovea was kept under observation as there was no presence of hemorrhage or fluid. And for the year, he received 3 sittings of PRP in the right eye. This is a sequence follow-up. His right eye vision, he maintained at 6/9 and 6. Left eye, he was 6/7.5 and 6. And the lesions remained stable, which is more prominent in the OCTA. So I want to discuss to the panelists regarding this case, whether this is a case of lymphoma like PCV, which was masquerading a lymphoma, or these are two different disease entities simultaneously? Or if it is a lymphoma lesion, based on the OCT images, was it possible to predict lymphoma lesions at presentation? I want to share my acknowledgement to Dr. Muna Bhendi and Dr. Pukrajishi, who helped me diagnosis in this case. Thank you very much.
Great presentation, Kalpita. Great case, great case. We'll be coming to this. I'm just going to there's a have a minor change. So I'm just going to request Dr. Diksha to present her case, and we'll have discussion, Kalpita, on your case and ma'am's case together, please, if it's okay. Thank you, thank you, thank you to the panelists for permitting us to do that. Dr. Diksha, ma'am, please, can we have your presentation, please?
Just a minute. So can you see my slides, Mohit?
We can, ma'am, and hear you loud and clear. I'd just like to briefly introduce Dr. Diksha Katoch. Ma'am has been our senior all throughout at PGI and is currently an assistant professor, soon to move out of the assistant professor grade and to be promoted, and has done avid work in pediatric retina, which is, I think, her calling, and she has a great case to show. Dr. Diksha, ma'am, please.
Thank you, Mohit, for the introduction, and thank you, Raman sir, for the opportunity. So after all these very interesting and challenging cases of uveitis and masquerades, I will be showing a relatively simpler case, but with a little surgical challenge. My patient was a 5-year-old female who was just presented at the beginning of September this year with complaints of diminution of vision in the left eye noticed since a week, which was sudden in onset and progressive. Her birth and developmental history were normal for age, and she had been diagnosed as primary congenital glaucoma at 2.5 months of age, for which she had undergone trabeculotomy with trabeculectomy in both eyes outside when she was 1 year of age in 2016. Postoperatively, she developed an inoperable retinal detachment with vitreous hemorrhage in the right eye. So in the left eye at presentation, she had high intraocular pressures despite medications and advanced disc cupping of 0.9. And she had a complicated course in the only seeing eye over the years, with a repeat trabeculectomy, and mitomycin C done in 2017, then a goniotomy done in 2018, then finally the placement of an ADI device in 2018 in the inferior quadrant, followed by a subsequent phacoaspiration with IOL implantation in December 2018. As per records, her visual acuity somewhere was around a little bit around 6/60, and IOP had been controlled on Dorzox T since 2018. So at this time, right eye had phthisis bulbi, and left eye, her visual acuity had dropped down to hand motions. Intraocular pressures on dorzolamide timolol were 10 millimeters of mercury. Anterior segment showed the presence of Harb stria, a posterior chamber IOL, surgical peripheral iridectomy superiorly, and the ADI tube could be seen in the inferior nasal quadrant. Posterior segment had advanced disc cupping. The media clarity was grade 2 because of all the stria in the cornea, a mid-dilated pupil, and some synechiae. And as shown in the OCT, there was a macula of inferior retinal detachment and the presence of a hemorrhage at the macula. So our surgical plan was first to try doing a scleral buckle with subretinal fluid drainage, because this was an inferior detachment. This was a young child, and we all know the challenges in hyaloid removal in such cases, and also because of the compromised cornea. But the issue here was the ADI implant in the inferior quadrant, and the challenge was the placement of the tire in the inferior quadrant. So a small literature search, what I did was that as we all know, that placement of an episcleral plate of the glaucoma drainage device in eyes with scleral buckle remains challenging. And I could come across only one case report in which scleral buckle had been applied in eyes with a previously already placed GDD. And this patient was an adult with a giant retinal tear and was managed with a pars plana vitrectomy and an encircling band, so not a tire here. And the encircling band was attached to the BGI, or the bar vent implant, to incorporate as a component of the encircling scleral buckle, and reattachment without intraocular pressure complications had been achieved in this case. There are few series of placement of the glaucoma implants following a scleral buckle, and these are the two types, the two techniques which have been reported. That if the retinal detachment surgery has been done more than 3 months apart, so wherein we expect that the fibrous capsule around the buckle has already now developed. So in those situations, a silicone tube or a long Krupin valve implant was placed within the fibrous capsule with and to variable lengths, and even sometimes reaching below the recti muscles. However, this type of technique has an issue that frequently the distal end of the tube can get clogged by the fibrous tissue, and it may lead to failure of the procedure. So to prevent that, to prevent the tube obstruction at the distal end, and there have been reports of tube migration, venting slits have been advised to be placed in the tube to prevent obstruction. However, this type of technique may require multiple surgical revisions, and the failure rates are also close to 40%. The second technique that has been described, and this is if the retinal detachment surgery with the placement of the buckle is less than 3 months duration. In this case, trimmed Barwell, as you can see that this is a shortened, normally the Barwell implant has a plate length of 32 millimeters, so it has been shortened and it has been slided under the tire, and then the tube has been placed into the anterior chamber with a kind of a silicone tube initially to prevent the hypotony, because this is a non-valved implant. However, to pass this plate underneath the tire may be challenging, and sometimes scleral perforations can happen if there is a scleral ectasia beneath the buckle. So one case series of combining the placement of the glaucoma drainage implant along with surgery for retinal detachment is there. 30 eyes of 30 patients, mostly adults, no eyes with congenital glaucoma. And in this case, none of the cases had a tire, and most of the cases, the 240 band was placed, and the Barwell implant was inserted above the scleral implant, and the tube insertion was done in some situations in two conditions, like it was done simultaneously in a group and delayed variably from 1 to 24 months in the other group. The IOP control was achieved in 82% cases, and retinal attachment had a success rate of 93%. So this is just a short video of how I did the case. So in fact, the glaucoma consultant, Dr. Sushmita, she came in the OT because she was so worried that after so many procedures, that if I could just do something that I don't remove this this implant there. Also, there was one thought that I could, if I could remove it at this sitting and then a subsequent surgery and place it in the superior quadrant. Now, the problem with that would have been that in case this scleral buckle had failed and the child would have eventually required a vitrectomy with silicone oil tamponade, it is important that in eyes with silicone oil, we always have to place the implant inferiorly, and then we would have landed a problem. So in any situation, placement of this implant had to be done inferiorly only. So we thought of that, how we could not remove this plant and also perform the buckle. So the first thing, and this is the most very important thing, was she advised me that you just ligate this tightly, this the tube of this, because as soon as the fibrous capsule will get incised, there is going to be hypotony. So after that, after using a 6-0 Vicryl to tightly ligate the tube of this implant and tagging the recti muscles and performing the cryopexy, the fibrous capsule of the implant was excised, isolated and excised. As you can see in this case, this thick fibrous capsule, and this Barwell implant was cut in half. And like you can see here, after this, the 240 band was passed in all the other quadrants and tied with the 50 Dacron sutures, since the tire had to be placed inferiorly and brake was inferotemporal in location. So the 277 was placed in inferotemporal location after further trimming. Like you can see here, this Barwell, this RD implant is further trimmed just medial to the medial rectus, and I have shortened the length here. After that, the mattress sutures, as usual, this usual steps of scleral buckle were done, and 2 mattress sutures in this quadrant and 2 more in the other quadrant. And herein, if you see that the 240 was placed over the implant, and the mattress sutures kind of secured it, and the two holes in the middle of that kind of help to stabilize the 240 band over the implant, because the implant doesn't have the groove wherein the normally the 240 slides in. So after that, drainage was done, and the sutures were tied, and the conjunctiva was closed meticulously over this, and the vicryl suture which was used to tie was not removed, because otherwise it would have uh, when it would have led to hypotony right there and then, and the conjunctiva was henceforth closed. So this is the just follow up. The child has just come on Friday, so we expected the intraocular pressure to be highest, and so this was 32 millimeters of mercury because of the ligature, and we expect the suture to go take around 4 to 6 weeks to absorb. So the child has been maintained on oral acetazolamide along with the orzolamide timolol combination. However, the retina is attached. The child is counting fingers close to face, but is coming back, and the mother says the child has shown improvement of visual acuity. So the child has been advised follow up and close watch for intraocular pressures. So thank you. So to the panelists, I would like to ask the question that how would they have approached this case, and what is their take on this? Thank you.
Great case, ma'am. I think terrific surgery. Not just the skill, but also the intuitiveness to come up with that, given the one-eyed status, multiple surgeries, young patient, pediatric glaucoma. I mean, super, super. I'm just going to, so we're going to start the discussion with ma'am's case first, and then go on to the discussion for Kalpita's case. So regarding Dr. Diksha's case, and regarding, anything which could have been done differently, or anything which was, or any other modification or comments, I'd first like to invite Sangeet Mittal, sir, please.
First of all, I'd like to congratulate Dr. Diksha for managing this case excellently. I must really admit that I have not done such cases before. And I don't know what to say right now, but she has done it quite nicely, I think.
Thank you, sir.
Thank you, sir. Raman, sir, any comments from your side? Any other pointers or anything else that you would like to, tube ligation, anything on that, or any other comments you'd like to make, sir?
I think basically I was part of this whole thing when this case was being done, and I think the credit goes to Dr. Sushmita, and because she wanted to save this tube, and the idea was great, and then the improvisation by Diksha. I mean, retina surgery is, I mean, there are no rules there. I believe in that. There are no rules. You always improvise and try to do the best for the patient, and this is what has been done, and this is excellent results.
In fact, I must just mention that Sushmita ma'am did really come to the OT. She said that do something, but please don't remove this implant, because there is, and in case the child would require vitrectomy, ultimately it had to be placed there only, inferiorly only. So just don't remove this implant somehow. So just tried it.
Yeah, great.
I'll throw this now to Dr. Raja, and just take his comment on anything that he might have thought could be done differently, or similarly, or whatever, and any concerns with of trying to apply. And I know this is not an easy answer, but actually putting a 240 band on top of a exoplant, and any chances of further down the line scleral dehiscence, scleral rupture, scleral. I don't want to use the term necrosis, but basically scleral dehiscence, because of, if I can use the term, twin pressure on the sclera. Dr. Raja, please.
Yeah, I think very well managed. Overall, it's actually more of a learning for us rather than having to give any comments to you, Dr. Diksha. I think very wonderfully managed. What I would actually tell is that for most people, probably, they might have tried to avoid all this opening of the conjunctiva and trying to see where to fix the buccal. People may have opted for vitrectomy, but I think you did a great job of taking the difficult choice and the right choice. The question about Mohit is about about scleral necrosis.
I'm just trying to play devil's advocate, sir. I'm just
No, I'm just twisting the question a little bit. So I'm not worried about the future, but I would have been worried if during the surgery, if you had tried to go in and planned all the surgery, you have found after trimming all the buccal implant and removing the capsule, if there had been any problem with the sclera at that time, then that would have been more troublesome to manage the complications there itself. So that would have been. So I don't know whether we should be ready with a scleral patch graft at that time if we find any problem. Maybe that, I don't know, maybe you already had it in mind and you were prepared. But that's one thing I would keep in mind, that whenever I'm going in for these difficult cases, and god forbid if we end up in some problem while dissecting, while freeing up space, if there is an issue, then we should keep a sclera graft ready. That's the only thing I have in mind. Otherwise, I don't know how I would have managed. In fact, I probably we should be referring it to you then now if we get any such cases, because you have the experience also. You did very well. Thank you very much.
Thank you, sir. And I think it was a wonderful comment, sir. I think I did not anticipate. In fact, I did not have a scleral patch graft, and definitely it would have been a challenge if I would have found scleral thinning at that time. And God only knows maybe what I would have done in that case. But yes, this I would keep in mind if the further if I have to do a subsequent case. But again, would just a question again to the panels, that would would you have considered vitrectomy in any situation in such a case, or that my decision to still try a buckle was okay?
No, so from both the retina surgeon's point of view, buccal is preferable, and from a glaucoma surgeon's point of view also, in the sense, other than disturbing the implant, I mean, they don't like oil in the eye when it can block the tube from inside, so that creates more problems. And we could see from the fundus photograph, there's advanced cupping, and we don't want an implant to go waste, with silicone oil blocking it. Sometimes what we have done is, initially, to prevent any blockage, for and see the response, you can put a silk suture into the inside part and make sure that it doesn't block it. But then after that, you have to remove it after some time. It's not easy, but I appreciate your effort in taking it the long way. Yeah.
Thank
In
you for
fact, in the photograph that we are seeing, we have a good indent in the inferior nasal quadrant from that. And all the series, Mohit, as you said, the scleral necrosis, all the series till now, wherever they've put a 240 over a previously existing glaucoma drainage device, they have not reported any migration or scleral thinning. So wherever band has been put till now in all the series, it has been placed over the implant and sutured up.
Great. Thank you, ma'am. I think
Mohit, just one thing I was just wondering right now, whether it could have been cut the tire, just spare that area and then place another tire adjacent on the other side, and then bridge it with the 240, and just the implant acts like a buckle, whether it could have been done.
So, sorry, I didn't understand. So, because the brake was inferotemporal, the tire was placed there. And here in this quadrant inferonasal, the plate of the implant, the trimmed plate, because it's like 6-7 millimeters. So, applying a suture very posterior was very difficult. So, that is why it was trimmed into half, and then it was used as a tire, and then secured with a 240 and sutured up.
Yeah. Thank you. I think it's a very well managed surgery. I won't prefer to do a vitrectomy in a child 4 years old. It's very difficult to manage them post-operatively.
calls for a publication as a surgical technique, as I would say, ma'am. And with that, I'd like to thank Dr. Diksha for that excellent case, and dive straight into Kalpita's case. And I'd like to ask Dr. Raja Narayanan sir his comments first, and then I'll go to the other panelists regarding Kalpita's case, which was actually equally astounding. Oncology, medical retina, a mixture of was it a PCV? Was it PDR? Was it both? It was definitely lymphoma? Was it what was it? And could we have picked it up earlier?
So I would like to share my screen here. Again, very nice presentation, and these are the dilemmas and challenges which should be brought out and discussed. Overall, yes, I could see PDR. I could see a lot of peripheral ischemia in the left eye also, and also there were some very vascular leakage, which was unusual for a PDR. In your left eye, it was very prominent, where there was no neovascularization later on, but definitely there was macular neovascularization. Yes, in terms of PCV, I did see lesions. Now, PCV can be of different types. One is the exudative type, where we treat it like an ARMD more or less, and then you have the hemorrhagic type, where you have some differences in terms of their presentation, FA or ICG. Now, I just was, when I saw Dr. Kalpita Das presentation earlier, and immediately it struck, in one of my cases I had some FA and ICG features just enlarged. So this was again an extramacular PCV. Now, extramacular PCVs generally are more of the hemorrhagic type, and they are less often associated with a branching vascular network or a new vascularization network. That's why whenever you see PCV nowadays, people are also calling it as a type 1 aneurysmal CNV. Basically, it's a choroidal neovascularization with aneurysmal endings. But you do have the other variety of extramacular hemorrhagic PC, where you may not have a CNV, a type 1 CNV. So they are actually the typical, or where you have to call them as PCV and not as type 1 aneurysmal CNV. But in this case, where it was hemorrhagic PCV, and which was similar to Dr. Kalpita's case, we have RP changes which are similar to what you had shown. This is not often. I looked at quite a few of my ICGs and FAs of different hemorrhagic PCV patients. I did not find that very often. But in one of the cases, I did see. What I'm trying to say is, while you mentioned about the leopard skin pattern, it may not be the clincher for a lymphoma, as it was in the previous case of Dr. Priya, even ciliocoroidal effusion. There can be multiple reasons for a leopard skin pattern of RP. I would, in fact, if you really want to clinch the diagnosis, we should go in for a vitrectomy, do whatever PCR testing and also cytology, and then clinch the diagnosis in a way that, okay, yes, now patient had ileocecal lymphoma, and I have now proven intraocular lymphoma also. But just the presence of ileocecal lymphoma may not be that appealing for me to say, based on leopard skin appearance, to have an intraocular lymphoma. I mean, unless obviously you have a primary intraocular lymphoma where you do a CNS tab, you find that's a different issue. But just an ileocecal lymphoma, with this, I would probably go in to do further testing of the intraocular lymphoma before I label it as an intraocular lymphoma.
Great. So absolutely, I think the moot question, as you alluded to, Dr. Raja, was whether we have confirmation or we have any evidence, or that we can say with certainty that the intraocular changes are secondary to the lymphoma. Keeping in mind that the secondary lymphomas generally don't tend to involve the retina as much as they would involve the choroid, and the presentation would be would be a lot different from what we are routinely geared towards looking at in a primary vitreoretinal lymphoma. Absolutely great point, sir. Raman sir, can we have your comments on this case, please?
I think most of the points Dr. Raja has taken care of. Kalpita, one thing is, you asked that is there on the OCT, can we find out, differentiate between the two? The OCT-A does show this angiogenesis there. There is no doubt about it. Now, if you go to the first OCTs, apart from the lesion there, I see some bumps there below the fovea also. I think it is there. We have to rule out whether we are seeing those bumps like drusens there clinically or not. To me, I see those hyper-reflective dots there actually, and we have to see those clearly. And it appears to me that it had some subclinical disease at that time also when the patient presented. And yes, once you give these patients anti-VEGFs, even lymphoma does tend to resolve. It has been shown systemically that in the systemic lymphomas, they give bevacizumab to these patients to take care of the angiogenesis, and probably some amount of anti-VEGFs to this patient has taken care of disease, lymphoma also per se at that time. But two can exist together. It has been the AMD and lymphoma together has been reported, but I've not come across the IPCV and lymphoma thing. I don't know, I may be wrong, but I would have a look at the OCT again, because it is giving us the clues that something is happening below the foveal center in both the eyes in this patient actually. Yeah.
Thank you, sir. Dr. Sangeet, can we have any comments from you, sir, on this case?
I think now it has been covered by both Raman and Raja, and I think that it was a difficult case to manage. With three diseases existing in one eye or both eyes, I think she had done quite nicely.
And Kalpita, what was there in the vitreous? These were asteroid halosis, or are you?
Yes, sir. So initial presentation, it was very difficult to make out any finding because he was a diabetic. I could see some retinal hemorrhages. There was a pre-retinal hemorrhage. There was a vitreous hemorrhage, and he had dense asteroid in both the eyes. So that was initially to make out anything what was going under was very difficult.
I know it's very difficult.
I could not pick up anything on FFA ICG in any of the phases.
But the later on the picture is the leopard skin is favoring the secondary, of the lymphomatous changes actually.
So if the initial presentation we say it's a breakthrough hemorrhage due to PCV, would there be likely a subretinal bleed component also along with, or just a breakthrough hemorrhage can occur in PCV? Because we didn't see any remnants of any subretinal bleed later on.
Yeah, so that in fact it's very difficult to say what was there in that all the block fluorescence that you had. Whenever you have a breakthrough hemorrhage, that can be a bigger size than the subretinal hemorrhage, so you may not be able to see. And then the later on RPE atrophy which happened can correspond to what was there subretinal initially. It's possible, but again it was a difficult case, with all the asteroid halosis and the pre-retinal hemorrhage. It was not easy to see through. So I mean overall it's like it's a difficult case. Even now I would say that we should be on the lookout for any further lymphoma changes if at all you are expecting. But if you see anything again, maybe worthwhile to go in and take a biopsy in this patient.
Absolutely, I was about to come to that.
Sir, I have a question. I just want to know, if already we have a tissue diagnosis of ileocecal lymphoma and seeing some clinical features in the eye, do we need a separate tissue biopsy to say it as an intraocular lymphoma?
Yes, because I'm not sure if it's a lymphoma just based on the leopard skin appearance. I mean, if I see any other lesions of lymphoma, I would still tend to, even if otherwise I would like to confirm, but just the leopard skin appearance by itself, as was shown in the previous case, the ciliocoroidal effusion also, you can have a leopard skin appearance. I showed my patient of PCV who just had hemorrhagic PCV. This patient has a very long follow-up. There is no lymphoma in that patient. So it's just that, earlier people used to think if there is a retinal tract, it's always a CSR. Now we know it's just a chronic effusion. There can be multiple reasons for that chronic effusion. So I would say that if there is another lesion, if it comes back again, if it's hemorrhage, then it's unlikely to be lymphoma. But you be on the lookout for any other lesion if it comes again.
Thank you very much, sir.
Absolutely. Great points, everyone. I'd just like to request Dr. Veer Singh to start to share his screen, please. And after that, if he can have Dr. Sangeet Mittal, sir, your videos on managing post-cataract endophthalmitis, endophthalmitis, and we'll discuss both the cases after that. Before I introduce Veer, just a request to the viewers, and there are quite a few questions. They're actually in the chat box. We haven't addressed them. Please bear with us. We will address them towards the end. And mind you, we'll try and ensure that all questions are taken and answered to the best of our ability. With that, we come to Veer, again, my friend from Amritsar, and he's after his training from Shankar Netralaya. He's now does extensive surgery at the famed Dr. Sohn Singh Eye Hospital in Amritsar, Punjab. and he's going to be presenting, I think, something which is not exotic, but something which will affect most people here, because everybody has to deal with endophthalmitis. So looking forward to Veer's case. Veer, please.
Thank you, Mohit, for the kind introduction, and thank you, Ramandeep sir, for arranging this program and having me here. So like Mohit mentioned, I'm not going to be presenting anything exotic. It's going to be a very basic, simple case. The whole purpose is that when I was, initially when I used to do these cases, it's a case of traumatic endophthalmitis. I read a lot of literature and I spoke to a lot of people what was the best approach, and everybody had a slightly different take on it. So I thought, why not put it on a forum where we could actually discuss? I mean, I went one way, but there are multiple ways of managing it, and it would be a good idea to have such a basic case and then discuss the various ways we can treat to have a good outcome. So to start that, this was a 13-year-old boy who had a history of stick trauma in the right eye 5 days back. The presenting vision was PL, and PR was accurate. The cornea was a self-sealing, it had a self-sealing wound. AC was full of fibrin exudates, and the lens was cataractus, and fundus, there was no view of fundus. So this is just I don't have a pre-operative picture. This is a picture after lensectomy. So I thought after removing the acid exudates, give some idea about the clinical picture. A gentle USG was done since the wound was self-sealed. Vitreous exudates were seen filling the posterior segment, and the retina was attached. There was no foreign body or anything seen on the ultrasound. So the diagnosis traumatic endophthalmitis. I decided to do a corneal suture the cornea at the same time, do a lensectomy, vitrectomy, and intravitreal antibiotics along with dexamethasone. So what I do is I take an AC sample and a vitreous sample, and then I send it across to the lab. We have an in-house lab, and they just do a basic grams and QH. And meanwhile, I'm done with the vitrectomy. At the end of surgery, I get a report saying whether it's a fungus or a bacteria. So I inject, it came out as a gram-positive cocci. So I injected Vancomycin deca. Now, intraoperative decisions and dilemmas that I was talking about, this is what I had in mind. So since it was a case of advanced stage and it was a fulminant endophthalmitis, whether to do a extensive radical vitrectomy with a PUD induction with or without silicone oil injection, or considering the inflamed or the necrotic nature of the retina, just do a core vitrectomy to the extent without possible control the infection and leave it for another day for a media clearing vitrectomy. I'm going to show the surgery. To start with, I'd like to point out that to start with, after putting the trocar, the cannula, I was not able to see the infusion from the back. So I decided to, after removing the AC exudates and putting iris hooks, I decided to put the infusion in the at the limbus to start with, did a lensectomy, and then after clearing the anterior vitreous and doing a proper lensectomy, then shifted the cannula behind, where I could see it well. Then initially I thought maybe I'll just do a core vitrectomy, but then because the retina was also very inflamed, but then my heart was dwindling between, looking at the condition of the eye. There was so many exudates, it was such an advanced. I just put in a posterior lens and I went for the posterior hyaloid very carefully. And to my luck, I was able to find an opening in the posterior hyaloid. It was slightly lifted at some area and it was attached at the others. So I did not use any suction. I just, at that same place, I just continued to use my cutter and just go around the disc area, trying to stay a safe distance from the retina. And to my luck, I was able to debulk and I was able to, slowly chew up the posterior hyaloid all around the disc. And here again, a little debulking. And if you notice, just right after this is the last part of the hyaloid, which is attached at the nasal side. So again, no suction used, just at the cutting mode with high cut rate. And then there's the last portion of the posterior hyaloid that comes off. After that, you can see the hyaloid is, the vitreous is all lifted up, and then I go ahead and do a peripheral vitrectomy. Again, a safe vitrectomy from a safe distance using low suction. And you can see the retina is very inflamed, necrotic, and there's a lot of vasculitis also in the background, and a lot of necrotic exudates that are lying in the posterior pole. So once not being too aggressive, I decided, okay, this is the best thing I can leave it with, and I left it right here. Not to my surprise, there was a detachment with a GRT RD, which was expected, which is expected in endophthalmitis case. There was some PVR memories also at the edges. After peeling them off, went ahead with a full fill. There was not much to be done. Just a routine GRT surgery was done. I shaved that base nicely because those exudative membranes can cause low IOPs later. So I shaved those membranes at the pars plana very well. And then a PFCL full fill was done, followed by a 360 laser. And just like, you do a routine GRT surgery. So there were these little retinal folds, but I just left them right there. And a 360 laser was done. And again, buckle was also put in this case because I didn't know what to expect inside. Belt buckle, 240 band was put, and a PFCL all exchange was done to attach the retina. So at 6 weeks follow-ups, the follow-up, the retina was on, and the best corrected visual acuity improved to 636 with silicone oil C2. So the main idea of this presentation is to discuss the things here. So just going to a very basic thing. It's all in literature, but yeah, the pathogenesis, what could be the real pathogens? Did I end up having a iatrogenic break with my cutter or something? Did I pull the, have a traction on the peripheral vitreous too much? Or was it the necrotic retina, which anyway was going to go into a GRT detachment? Then again, this was an advanced endophthalmitis, and I chose to do an extensive vitrectomy. So was going after the posterior hyaloid, just even on the cutting mode without any suction, to doing extensive vitrectomy was a bad decision, which brings me to the discussion whether we should be doing an extensive or a core vitrectomy in these cases. And last but not the least, could silicone oil tamponade in the primary surgery, even without a detachment or a break on table, could have prevented this from happening, which brings me to whether we should be using silicone oil in these advanced cases in the primary surgery, and anything else that I could have done. So with that, I end my case and I open the case for discussion.
Thank you. We will come to that after Sangeet sir's presentation, and we'll have discussion on both together.
Do you want me to stop sharing, or do you want these questions on the screen?
No. I know the questions, Veer. I'll post them to the panelists. Please, thank you, Veer. And Sangeet sir, can we have your presentation, and then we'll discuss both of these cases, both these kind of similar linked things together.
Mohit, is my screen visible?
It is, sir.
Okay. Thank you again, Mohit. Just coming back to the 27 gauge in complex cases, whether it's possible or not. 60 years, this is a 60 years old female, 15 days post cataract surgery with vitreous hemorrhage, retinal detachment, subretinal hemorrhage, and a choroidal detachment. She was seen, and this was how it was managed. Veer, is the audio audible? Is the audio? Oh, sorry, Mohit.
No, sir, it's not.
Okay, then I'll just go back and speak side by side. This was a patient who had all these problems. So once we started, we had found that there was choroidals, and so what I do is use a 26 gauge intravenous catheter to drain the choroidals. Once you enter the space, you remove the stellate and leave only the plastic thing behind, and it wonderfully drains all the choroidals. Then you make a retinotomy here, and through a small hole, first aspirate all the subretinal blood that you can, because then if subretinal blood starts leaking into the vitreous space, it will obscure the media, and then you can extend your retinotomy, remove all of the blood, use a chandelier light along with it, and then just further just put PFCL, do laser, and exchange PFCL with silicone oil. So you can do these type of cases also with the 27 gauge vitrectomy. So this is just using silicone oil, and this is 2 months post-operative. Patient had 624 vision in this eye. This is silicone oil inside the eye. The patient did not come for silicone oil removal because of this COVID time. I think she'll come later. So this is another patient. She's a 56-year-old female, 2 months post-cataract surgery. Best corrected vision was PLPR accurate, and she had endophthalmitis with retinal detachment. And again, we did this case, 27 gauge vitrectomy. First of all the interior exudates were removed. The media was cleared off, and there was a thick membrane all over the retina, which was again peeled off using the cutter itself. In addition, we used end gripping forceps sometimes to remove all this posterior hyaloid, which was stuck to the retina very badly. And again, after removal of this, after peeling of this posterior hyaloid, again the vitrectomy was completed. All the exudates which could be removed were removed. Then the fluid air exchange was done, and 360-degree laser, and then silicone oil was exchanged with air. Again, the intravitreal antibiotics were given at the end of the surgery. So thank you. Just sharing these cases, just to say that 27 gauge is not a deterrent to do complex surgeries.
Absolutely, sir. Great cases. I'm going to throw the discussion.
You're not audible.
Sorry, sir. Am I audible, sir?
Yeah, you're audible, sir.
Yes. Sangeet, sir, great cases. I'm just going to start the discussion with you, Sangeet, sir. If you could just take a few of the questions that Veer had posed, primarily two, that particularly in traumatic endophthalmitis, would you go for silicone oil injection in the first surgery, and or what would be your indications for doing a more aggressive vitrectomy in the first go as opposed to a not so aggressive vitrectomy in the first go, and anything else that I think
Dr. Sangeet is not able to listen to you.
Is not being able to. Oh, okay. Sir, can you, sir, can you please? He can't hear me. Okay. Raman sir, sorry. Can you take those two questions, sir, please? That especially for traumatic end-off, the role of oil in the first surgery, and this is RD. This is traumatic end-off without retinal detachment, and the role of a more extensive vitrectomy, not to be done ever, done in selected cases. If yes, then any adjuvants to be added or any other caveats for that, sir.
Actually, excellent video. You have opened a Pandora box. I mean, we can discuss this topic whole day. I mean, the thing is, what happened was the vitrectomy became more forgiving. So we have all moved from a thing called a core vitrectomy. We have all tried to do now remove as much as vitreous possible. This is what we do try to do, and as long as you're comfortable there, this is what we are doing nowadays. So if I remove hyaloid in these patients, I don't remove hyaloid in these patients. If I put oil in these patients, I don't put oil as a primary in endophthalmitis. And those who put, why they put it? They put it in the cases who are one-eyed, who are very bad. They try to remove the hyaloid in the surgery and take care of the breaks in the necrotic retina and put oil in these patients. Those are desperate attempts to save the eye. If patient's other eye is fine, I don't think you should go desperately and try to remove the hyaloid in each and every case. If it is coming easily, like you said, I mean, you can do it. But RD and GRT type picture in these patients do happens in the best of the hands. It's not every time that your cutter touches the retina causes that thing. It is sometimes the traction there per se, because you leave the hyaloid there, there will be a zipping, and from one area the retina start detaching and it will zip open like a zip there. So I mean, if it happens, it's all right. And but the thing is, the early follow-up of these patients and recognize that tear as early as possible. This is what you did in that wonderful that you saw the tear, and then you went now with a planned thing that I will put oil now, I will put buckle also there. I'm very fond of buckle in these patients. If you ask me, I would love to do randomized trials of putting buckles in these eyes, of where I do these desperate vitrectomy with endophthalmitis. I put a buckle in one eye, and next eye I will not put it, and then I will I will look at the results, especially in the trauma cases. So, but not oil in these patients as a primary surgery, because oil can do problem there. There is a lot of sequestration of the exudates, cocooning, fibrosis, and these eyes will have cyclitic membranes. The hypotony will never recover, and you will never be able to take out the oil in these patients. And eventually, in 4 or 5 years, these eyes will, you lose these eyes actually. This is what my take is.
Absolutely, sir. Points taken. Dr. Raja, your comments on the questions raised by Veer, and also what's your approach on for traumatic endophthalmitis, aggressive versus maybe not so aggressive, and do you do any dose adjustments for intravitreal antibiotics in cases in which you do put in oil in end of RD or only end of cases?
Again, these are always challenging cases, but very nice presentations. What we need to understand is when we say in the modern era systems are better, viewing systems are better, we can do more vitrectomy, but it doesn't mean that we don't cause harm. We can still cause harm, as was seen in this case. I'm sure if you had not done vitrectomy in this case, you would never had a GRT in this. But it's a question of how much to go after. If you cannot see, never do anything blind. That's the dictum, because I have seen patients losing eyes from retinal detachment rather than endophthalmitis. In this case, the patient was fortunate that they came to you, you could diagnose, and you were willing to manage. Many patients either will drop out or are left undiagnosed, and then you later on see that there is a funnel RD somewhere. Recently, I had a similar case, a young girl, where an aggressive vitrectomy was done, but now as I can see the RD now through the aphakia, all the retina lying near the iris. So it has to be under visualized. If you have view, if you can go like you did a good job. You could see everything, but still these patients can land up in GRD. I'm cautioning against cases where people are in a hurry, like endophthalmitis. You just do some core vitrectomy and come out. That cannot be the approach. If you want to do a more extensive vitrectomy, make sure that you can see them. In your case, I can still understand that you are trying to see why it developed in your case when you could see everything. But the peripheral excision, vitreous base, I will not do that. Because you never know when you have touched or when you have created traction, when you have. These are necrotic retinas. Even a little bit of suction can cause, even if you have not directly touched them. So peripheral vitrectomy, I will do more than what I do in regular core vitrectomy, but not go to the periphery as such. In terms of intravitreal antibiotic dose, first of all, silicone oil, what Dr. Dinesh Palmar and Dr. Lalit Verma in their RPC days when they published this, it was for the antibiotic property of silicone oil. It is not just for retinal detachment. You even do in regular endoffs, and you can do it for their antibiotic property. In fact, sometimes I also use it in cases where I don't find the organism microbiology is negative or it's not responding. You can inject oil for their antibiotic properties, but again we have to be careful. You don't use it in every case where it is can be managed. At least not in the first attempt. I don't do, because what Dr. Ramandeep mentioned, it can lead to problems of severe fibrosis in the periphery and causing ciliary body traction and chronic hypotony. That's a problem which can happen. In terms of adjusting the dose, at least for the antibiotics which we regularly use, Vanco, Cefta, I don't adjust the dose. They are pretty safe. If you are using the aminoglycosides, you definitely have to be very careful. But otherwise, I don't adjust the dose.
Absolutely, sir. I think great. I think all great points. I just would like to add two small points out of what I feel. I think any point in time that we apply iris hooks, and iris hooks we all understand were mandatory in this case. They do dilate the eye in a much more unnatural way than a regular, let's say, dilating pupil would. So it's square. and you do get to see a lot more with wide angle viewing systems than you would in any endophthalmitis eye, which is not being actually, the pupils not been dilated by iris hook. So you are inadvertently, because the mind is trained to, let's say, operate in that kind of area, which you might see in a non-iris hook applied eye, and your mind might know that that's the as far periphery as I'll go, but with hooks that area is that, and you might inadvertently go a little more further than you would otherwise, because the pupil is irregularly and more dilated than otherwise. And also, I think that the fact that you had preoperatively known, thanks to excellent macrobiology support that you, I think, have, that this was a gram-positive cocci which is sensitive to ABCD. I think in these patients, when the sensitivity was known, you knew what to give, both intravitreally and systemically. I think also should have, you could have maybe held your hand a bit, if I can use that phrase, as far as the aggressiveness of the vitrectomy was concerned, knowing the microbiological profile and the fact that it was not fungal, it was not gram-negative bacilli, it wasn't multi-drug resistant. So maybe that could have been something. But again, this is hindsight, and my 2 cents worth of whatever that was. Great case, Veer. Great
So I
videos,
think
Sangeet.
I agree. After this happened, I did a lot of literature, spoke to a lot of people. So I think I would take Dr. Raja's point, because I agree with him. Maybe if a PVD is coming off, PVD is coming easily, that's okay to do. But then again, if I have to go back and do this case again, I probably would just remove the vitreous up till the equator and not go beyond. So I think I would do that.
Great.
I think very well managed. Very well managed. I think great case, Veer. Great case. And as I said before you started, presenting, that this is something which will generate more discussion because everyone's gone through it. It's not a rare exotic case. So thank you for
Everybody
that.
has probably done this case.
With that, I'd like to invite Dr. Divyansh Mishra to please share his screen.
Thanks, Mohit. Thanks. Yeah.
And Divyansh again is our friend from Bangalore. He does great work. In medical surgical retina. Also has interests because of the institute where he's from, in on oncology. And by the looks of it, is an English aficionado. So he's going to be speaking to us on absquatulate. Hold your breath, everyone. Epiretinal neovascularization. And I can't say anything more about that case. So over to Divyansh, please.
Thanks, Mohit, and thank you, Ramandeep sir, and thank you whole team PGI for giving the opportunity. So just to add a little spice to it, so abscatulate epiretinal neovascularization, what does that mean? Is to leave abruptly. So that's why I started searching on Google, and that's why I found this kind of an abnormal term. Not a very odd case, but which I felt a little odd. That's why I'm presenting this. So this was a 58-year-old female which came to us with complaints of decreased vision since 1 year. She was a known diabetic and hypertensive, which was under treatment and with fair control. Best corrected visual acuity is around 6/18 in both the eyes, and near vision was N12. Early lenticular changes, and she had a history of laser done to both the eyes for proliferative diabetic retinopathy. So this is what when she presented to us. So we can see some kind of a pigment scar around the fovea, some yellowish discoloration around the fovea, and some pre-retinal hemorrhage, which is more visible in the left eye, but it was already lasered, but it was unstable. Vitreous hemorrhage was there in the right eye also, somewhere in the periphery. And this was the OCT scans. As what we can see, certain scans show that the hyperreflective material is at the border of ILM or into the vitreoretinal interface in both the eyes. And yes, vitreomacular traction is there more in the right as compared to the left. So these are different scans passing through the same area. Certain scans are not passing through the macula. As we can see, the visual acuity is not 6/6, 6/18 and 12. And this is again to reiterate that in certain scans, we can see that that hyperreflective material is at the border of vitreoretinal interface and just off the ILM is what I felt. These were the scans of OCTA, which we can see certain intraretinal abnormalities in the superficial slab. So these are the default slab in the TopCon machine, which we have. And when we changed it to the manual segmentation, where we turned it to the vitreoretinal interface, because there is no vitreoretinal slab per se in a TopCon machine, we can see certain loops of blood vessels or fronts of vessels at the fovea. Just to again reiterate that this was a manual segmentation which we changed and identified that. As you can see, we can see certain flow signals which are there in those areas which we are expecting that those loops are there and which are above the ILM, as we can see. Again, certain different areas of scans passing just adjacent to those areas to show that loops. This was the left eye. Again, some intraretinal abnormalities in the superficial vascular network, not much appreciated in the deeper ones. Yes, there is some neovascularization at the disc which is there, which we would be seeing much better in an FA. Again, this is also showing that this is the superficial slab or the retinal slab. Once we change it to the manual segmentation, we can see again that there are certain vascular network which is seen above the ILM, which are showing the flow signal. And yes, very well vascular front or some loops of vessels seen that in the left eye also. Again, similar scans in different areas just to show that where it is passing from, and again to state that those have vascular signal within that in an octa. So this was an FFA where we can see certain background diabetic changes, proliferative disease, which is seen at various levels, superior, inferior, and temporal to the arcades. In the left eye, neovascularization at the disc, and certain kind of abnormal blood vessels or vasculature at the fovea, which is in the late phase showing some kind of staining more in the left eye. So considering that the right eye had a gross VMT, we went ahead and did vitrectomy with membrane peeling. As we can see, certain membranes, flat membranes are there, and some vitreous hemorrhage inferiorly. So a triamcinolone PVD, some kind of a donut vitrectomy where we are trying to avoid the cap of the vitreous which is there at the vitreomacular interface. And then this is at the completion of the vitrectomy. As you can see, I haven't peeled ILM in this case. I was very jittery, not sure how much ILM would have effects, because this I thought was a case of PFT along with proliferative disease. So this is left with gas and then injected anti-VEGF. And this is post 2 months. As we can see, some very early ERM which is forming on to the nasal side. But as we can see, the pre-surgery where at certain areas we can see that the pigment or the hyperreflectivity which was there has gone sub-ILM. Probably the traction was the reason which was pulling the pigment into the vitreous cavity or the vitreomacular interface, which after surgery has gone back. This is what I felt. So these are again different scans passing through the same areas pre and post surgery. So the OCTA, this is the pre-surgery OCTA where we can see the vitreoretinal vascular abnormalities in the superior or the superficial vascular network, which is not very well appreciated in the post-surgery. And yes, the loops which was there has suddenly vanished right now. So we are unable to see any of those loops in the vitreoretinal interface over here, the segmentation as we can see. In the left eye, still at 2 months, we can see that the intraretinal vascularization or abnormalities are still there. But yes, very important finding in this is that the size has increased and the density also has increased. So this is at presentation and this is at 2 months. We can see that the size or the density or the amount which was there has much increased at 2 months. So this one more interesting finding which I could see when I was scanning through the B scan of the OCT is that the traction is not only at the pigment but also at a major blood vessel which is feeding into, or the vertical dip of the blood vessels which we usually see in a PFT. So this is one of the blood vessels which is in continuation with that pigmentation and which is having that traction, as we can see. So points to ponder in this case, which I am still not sure whether this is PFT with an ERNM, that is epiretinal neovascular membrane, or whether this is a neovascular membrane or a foveal neovascularization because of a PDR. And why did ER or the epiretinal neovascular membrane just regress spontaneously? Whether it was because of the laser or at the time of surgery or the anti-VEGF, and at 2 months it hasn't come back. And why did the pigment clump glow back or migrate sub-retinal or sub-ILM after the surgery? Does VMT play a role, which the paper published by Apurva and group has not stated that the VMT plays a role because none of their cases had any VMT? And what to do for the other eye, where we can see that the neovascularization is progressing?
Great case, Divyansh. Terrific documentation, and backed up by, I think, various, meticulously done surgery. So great. We're going to come back to this case after Simmer's case, and then discuss both of these together. So can I request Simmer to please, start sharing a screen, and Divyansh, can you please stop sharing, please?
There is some issue. I think that it has got stuck. I'm unable to come out of it.
Okay. No worries.
I need to probably restart and.
Yeah.
Sure.
So we'll be waiting for you to rejoin, I think, when you're.
Yeah.
And Simmer, can you please start sharing the moment?
Yes, sir. Sure.
Again, Simmer is currently a senior research associate with us here at the PGI, and again does his interest lie in surgical vitreoretina and also pediatric retina, and we should soon, have him on board as a member of our retina and especially pediatric retina unit. So, and Simmer is going to, although present, similar to Veer's case, I think diabetics are something that all of us come across in our VR practice, and everybody, runs into some kind of an issue doing diabetic vitrectomies. He landed up with a little bit of a unique issue, and let's see how he managed and what he could have or couldn't have done differently. Dr. Simmer, please.
Yeah. Can you see my screen, sir?
Yes, absolutely.
Okay. So I'm going to discuss about a fluid trap that I landed up in a diabetic patient, a 40-year-old female. I would like to thank Dr. Raman for conceptualizing this and Dr. Mohit for the kind words. So this was a 45-year-old female patient, known diabetic, diagnosed as proliferative diabetic retinopathy with fractional retinal detachment and vitreous hemorrhage in both the eyes. Right eye underwent surgery with fibrovascular proliferation dissection and fluid air exchange 2 months ago and had a good anatomical outcome. The left eye was planned for PPV now. So I'll just go straight to the surgery and what happened in it. So this was a standard 3-port 25 gauge pars plana vitrectomy done transconjunctivally. I'm entering at 4 millimeters from the limbus. A lot of vitreous hemorrhage, subhilar bleed, and the peripapillary tabletop like detachment you can see, proliferation you can see. So went ahead with the standard steps, segmenting the proliferation part by part, separating out the nodes, and then dissecting the proliferation over the nodes. So everything was going fine till here. This was also fine. So then when I just finished dissecting, everything was clearing out the blood. I could see this pocket of fluid at the posterior pole, which was kind of going like this over both the arcades. So I felt there I might have created a break somewhere and the fluid was coming in. So I proceeded with doing a laser photocoagulation first, at least to the area that was attached, rather than doing it under air. I had not seen the break till right here till now. So just as I finished, I could feel that I could not laser this area nasally, and I could see a break over here, right next to the thin retina, next to this clump of hard exudates, ischemic retina. Marked the break and proceeded with a fluid air exchange through that break only. And this is at the completion. You can see the fluid air exchange is complete. The disc is dry. Could laser around the primary break. But even after completing this, I could see a pocket of fluid right here, which is extending up till here, right where I had done the proliferation dissection also. I was not very comfortable leaving this fluid behind. I created a superior retinotomy superior to the superior arcade, tried to drain this fluid, but it wouldn't come. It was just trapped there. I tried doing laser to the retinotomy. I was not very successful, but at least I had some diathermy over there. And this kind of changed my plan from doing a gas tamponade to an oil tamponade, since I had a potential retinotomy which was not properly lasered. and there was a lot of fluid at the posterior pole extending beyond the arcade. So this was post-operative day one. Visual acuity was counting fingers 1 meter, large pocket of fluid as you can see on the OCT as well as the clinical picture. And the patient typically complained of a black dot in the center of his vision, just like our CSC patients complain. And as you will see under enlarged view, this retinotomy site appeared, there appeared to be some whitening around it. So some laser had come around it and it appeared dry, and the fluid was primarily at in this area of the retina. So I was comfortable just following up the patient, and this is 1 week post-operative. The vision had improved to 3/60. We can see that the fluid had started going down, and now the fluid was just trapped over here, and the volume had also decreased. And this was 3 weeks post-operatively. The patient gained a best corrected visual acuity of 624, and the fluid had largely resolved, much to my respite. So the questions that I have here is that for the panelists, that how comfortable they would be like leaving fluid at the posterior pole that was extending well beyond the superior arcade without creating a new drainage retinotomy, and what was the likely cause of this fluid trap that was created behind. Thank you.
Thank you, Simar, for a very succinct and very crisp presentation, and having asked two very crisp, pointed questions. We'll actually come to them after we finish off with Dr. Sangeet's final videos on managing diabetic retinopathy surgically. So can we have Sangeet Mittal sir, your videos, please, and then we come back to discussion of Sir's videos, Simar's case, Divyansha's case, and hopefully we'll be able to take some of the audience questions who seem to have been, I think, put off because we're not kind of addressing their questions. So we will. Dr. Sangeet sir, please.
Yeah. So Mohit, is the screen visible now?
It is, sir.
Okay. Thank you, Mohit. So again, going back to 27 gauge vitrectomy in complex cases, this is a case of proliferative diabetic retinopathy with a combined retinal detachment. And what I feel is like the 27 gauge vitrectomy has its maximum use in PDR cases, especially the PDRs with thick TRMs, with TRDs, complex TRDs. It's very easily managed with 27 gauge as compared to 25 gauge or 23 gauge. This is what I have felt over the years, and I prefer to do now all diabetic cases with 27 gauge. So this was a 51 years female, and her best corrected vision was hand movements only. She had a PDR with combined attachment. What I follow the technique is the modified end block dissection. I start the vitrectomy by lifting the membrane from the disc. Then I create a wedge from the center towards the periphery. And this aids in creating a good plane of dissection. So now this peripheral vitreous acts as a third hand to keep the posterior vitreous up, and you can easily segment and delaminate the membranes with the cutter itself. So the smaller sphere of influence of the 27 gauge cutter avoids the retinal tissue being engaged when you're doing vitrectomy in a mobile retina. And this small size of the cutter goes in smaller crevices for effective membrane dissection. And I call this technique as around the table dissection because you can attack the membrane from both inside as well as outside. And again, this 27 gauge cutter, because of its port, can help in lifting the membranes and causing all this dissection with the cutter itself. Again, very low flow rate makes the retina quite stable. So this is 3 months post-operative. The patient had a good visual acuity. These are some more cases which were managed with 27 gauge vitrectomy. All these cases with PDR and combined retinal detachments. Coming on to this last case, this was a 46 years old female, best corrected vision was hand movements only. And she was one-eyed, the other eye she had undergone vitrectomy elsewhere and unfortunately could not gain any vision in that eye. And she had a PDR with tabletop TRD in this eye also. And in this case, I did a bimanual dissection using a 27 gauge vitrectomy system. I do for a bimanual is in this case I use this 27 gauge 3x4 inch needle to cut all these epicenters and separate this membrane from the retina. And you can see all this membrane can be removed using the needle only rather than using any scissors or cutter. One single movement of the needle from can help in removing all this thick membranes. So this way, whole of the membrane was removed without causing any collateral damage to the retina. And you can see post-operatively, fortunately, the patient gained a very good vision of 6/9 in this eye. And two instruments I have used in this case, what I have modified, this I call as that as Meteor, using an old 27 gauge light pipe. Just remove this metal part from over this fiber optic, and then you can cut this fiber optic to a desired length, and you can use it as a chandelier light uh, with a 27 gauge system. And this is another, this is what I call a membrane stripper. Now this is something which we are developing in conjunction with some in an industrial company. We have this modified 27 gauge needles with a sharp edge, and then we have a hole made over, so that we can, if we have to do any proportional hydrodissection of the membranes, or if we want to remove blood along, which is sometimes bleeding which occurs during the membrane dissection. So which we are, this is something which we are developing at this right moment. It is called as membrane stripper. So these two things definitely help in these, could help in these type of cases. And again, at the last, I'll thank Dr. Ramandeep, Dr. Mohit, and whole of the PGI unit to give me this opportunity for presenting.
Thank you, sir. Thank you. Thank you for those excellent, actually having those excellent cases at every, step of this webinar, and for actually showing us what ideally should be done, sir. Thank you. I'm just going to quickly throw this up for discussion. And Raman, sir, if I can have your comments on, firstly, Simmer's case and, the two questions that he asked. Typically, and I would actually put it down to two scenarios. If in a diabetic FVP or a TRD, what you thought with vitreous hemorrhage preoperatively, intra-op after clearing the hemorrhage and after membrane dissection, there is no break, just a chronic TRD which wasn't visible preoperatively, and there is a lot of fluid, and you inadvertently create a break like Simmer did nasally. So you create a nasal break. So now it's a kind of like a CRD. Would in that case you just treat that break and leave the rest of the fluid the way it is, or go after the posterior pole fluid like Simmer did, versus the second option where it, after you cleared the hemorrhage and you thought it was a TRD, but after you cleared it, you found out that it was actually a combined retinal detachment. Then what would be your threshold for leaving back fluid at the posterior pole? Would you go back in that case and chase the fluid at the posterior pole, or would you still be okay with leaving it? So both the scenarios, please.
Mohit, those are great presentations by Dr. Sangeet and Dr. Simar, and then we'll go to the, I think, the Vinash case also.
Absolutely. We will, sir. We will, sir.
For the head kind of a case.
Yes, that's why I've kept it for the end, because it knocked everyone out of the park, sir.
So what happened is, what happens is, if you have inadvertently created a break, I will try to drain through that fluid from that break only, and will not chase to remove the fluid which is there in the center of the fovea. I'll not create another retinotomy to drain that. I know that this fluid is very viscous and very difficult to come out. If I don't remove it, it will take time to go. I know that this is going to happen, but I will not chase it, because I know that nowadays in vitrectomy also with wide angle, you try to drain it from the peripheral retinotomies, and some fluid is there in the center, and you give position prone to patient becomes all right. So in a combined RD, in adult RD, I will not chase for a posterior pole fluid in both the scenarios, and I will give a tamponade and give a proper position after that.
Thank you, sir. Dr. Sangeet, your take on that? Combined detachment located, kind of picked up intraoperatively versus a tractional detachment, chronic fluid, both having posterior pole fluid. Would you go for the posterior pole fluid in both cases or not go for them?
For a tractional retinal detachment, if there is no break, I won't create a break and remove the fluid. I'll leave it like that and let the fluid absorb on its own. But if the break is present, I agree with Raman. I will try to remove the fluid from the pre-existing break. And I don't believe in these cases to be that gas should be used. I will go in with oil itself, because this fluid is very viscous and it may take months to resolve. So if you have a fluid and you have an open break, then it's a disaster. If you have gas, so you need to put oil in these cases. Although these days many people don't agree to put oil in diabetic retinopathy, especially the combined detachments also. But I've actually experienced this happening. I tried the gas and the fluid did not go off. Although it was a very small amount of fluid, and I thought that it will go off very easily, but again, it did not happen. From that moment, I realized that it is a very big gamble if I use air. I'll always use silicone oil in these cases.
Agreed. And one last scenario, and then we'll. Sorry.
And one thing is, like, if you are not able to do laser around the retinotomy, what you can do is you can switch your laser to a continuous wave mode, and then you can do laser till you get the spot. You can do laser around this retina if you.
Yeah. So if there's a Veer, I'll just come to you, Veer. Just one last query to you, Dr. Sangeet, and then we'll take Veer's question. So if it's a chronic TRD, but there's an inadvertent iatrogenic break, as happened, let's say with Simmer, which is nasal to the disc.
Yeah.
So we kind of converted the TRD intraop to a CRD. So and as he did, all the fluid was out of that nasal break that was created. Yet there was that loculation of fluid at the posterior pole. Will in that case will you chase it and make a posterior retinotomy or leave it, sir?
No, I think again I agree with Raman on this, that I will try to remove as much fluid as from that break which has been created, and not exactly chase the fluid which is in the posterior pole. I think it is multiple pockets. Sometimes that happens there. Recently, I had two cases on the same day. In both the cases, I was able to manage the detachment without creating a break, but there was a lot of fluid left behind. And in one case, I did do a retinotomy and remove the fluid. In another case, I left it like that. Although the one in which I removed the fluid gained the vision earlier, but ultimately both the eyes were almost same in the post-operative results. So I chase that fluid now.
Absolutely.
I think just one comment actually. I think Raman sir and Sangeet sir have said most of the things, but I think when dealing with diabetic cases, the more important factor is to remove all the membranes in case there's any fluid. So and a break. If we leave the membranes, those can reproliferate, even open up, closed breaks. As long as there's no communication with the fluid pocket and the break, I think it's easy. It's just, you just leave the fluid right.
Good point. I think the threshold for leaving, agreed. If there's a break and you're using tamponade, I think the threshold for leaving behind any kind of prolifs, which as it is should not be there, I think should be absolutely non-existent. Agreed. We have Dr. Raja with us. Sir, can we have your final comments on these PDR cases? And then I would pose you the questions that Divyansh had for his rather unique case, sir.
Yeah, sure. So again, very nice presentations, even Simar. It's always challenging. While it is easy to tell in a conference that, if you don't have breaks, just leave it. If it's, nasal, leave it.
But then during surgery, it's our judgment, our call, and because ultimately as surgeons, we are accountable to the patient. You can't tell the patient that my conference experts who said so and so. So the point here is that you took the right judgment as long as you know that if there is a break which is there and you are not sure whether it is communicating with the fluid or there is another undetected maybe missed break is there, perfectly all right, you have not done anything wrong. But if you have just fluid, there are some people who may not be aware that if there is just some fluid because of traction, now we have released it, they may think that a traction detachment should settle down immediately. That's the point that we are trying to convey. But whenever, in many cases, as Apurva wrote in the chat box, many cases we are not sure whether we are missing a break or not. But the point here is that yes, some of these fluids are so thick that even with the cutter mode on, I have tried to aspirate this subretinal fluid with cutter mode on, still it doesn't come. It comes as thick as Helon or Helon GV. It's not easy. And yes, continuous mode is something I routinely use because there is always some shallow fluid, especially if it's diabetic. Unlike a regular reg RD where you aspirate, it will come out and then you do a nice laser. These cases, some fluid will come back or it is so thick it will not go away. Continuous mode is a good option. So overall, I would say that many of us are trying to settle the retina if there is any doubt about a missed break. In terms of gas or oil, yes, oil is preferred if you are not sure, if you have not settled the break completely. As long as you have removed the membrane, still you can have some fluid. But even under oil, this fluid can take many months to go away. So you don't have to rush in again, even if you see some fluid there. You don't have to rush again. Can I just share some of my slides for the next case
Please,
of
sir.
retinal neovascularization of
Please do,
Divyan?
please do, sir. Please do.
So again, very nice case which Divyansh presented. I don't know if I have pressed share button. Yeah, okay. Yeah, so it's very interesting that just a few years ago we started seeing these epiretinal neovascularization cases. I think Apurva, you have published it too, and one of the cases I came to know that one of our fellows, later on faculty, Rajan Gupta, had shared one case with you. I'm just sharing this one case where you can see the pigment clumping on the fundus photograph. There is some amount of neovascularization at the macula here. You see the PRP scars all over. This is again a patient of parafoveal telangiectasia. There is another neovascularization on FA, which is still, meaning it still requires some additional laser. But if you can see the OCT scan, you can see over the macula there is epiretinal neovascularization. Now, epiretinal neovascularization is not common in PFT. It's extremely rare. We have been part of many trials. We have had retrospective studies of more than 100 eyes of PFT, but it's not common to find epiretinal neovascularization. But one thing which I have found in common, I don't know why it's not going back. So one thing I have found in common is between your case and our case is whenever there is a PDR, maybe the stimulus, VEGF stimulus is so much that whatever neovascularization is there, the VEGF levels in the vitreous probably attract the neovascularization to come towards the vitreous. But normally, if the VEGF load is not high in the vitreous, the neovascularization should go down towards the choroid. But if the VEGF level is high in the vitreous, then it gets attracted, breaks the ILM and comes towards the vitreous. That's a difference I can see that PFT, at least as far as I know, maybe Apurva can tell us. As far as I know, in non-proliferative, I mean non-PDR cases, the PFT neovascularization generally tends to go down. But I have seen at least in this case PDR where we are finding epiretinal neovascularization.
So can I make a comment?
Yes, absolutely, Purva. I was coming to you from the
You
Yeah.
hot.
should be the one talking about it.
Yes.
So there are two things in diabetics. One is that the diabetic patients have a higher prevalence of macular telangiectasia. At least if there is no association, also we see a lot of coexisting diabetes in MACTEL patients. That's been seen in a lot of studies as well. So now there are two things. Diabetic retinopathy, when it is there, especially in a setting of PDR, having foveal neovascularization is not that uncommon. So the problem comes when there is a mactel, and whether the neovascularization over the fovea is related to PDR or it is related to mactel. So I tried to bring out some differences in this. What we saw consistently in epiretinal neovascularization related to mactel was that all ERNs had a PFT with associated pigment, and that pigment was not associated with any degenerative spaces or an ILM drape. So we saw ERNs in patients who had advanced mactel, as in if there is a pigment associated or there's extreme retinal thinning. In such cases, we found that it is ERN, and this is in a series which had no DR. Now, coming to the subset of patients who have PDR, and to differentiate between mactel associated ERN and foveal neovascularization of PDR, it becomes simple because ERN, if the foveal neovascularization of PDR would not be associated with advanced mactel, as in say pigment. So we saw that foveal neovascularization are more florid, they have thicker dimensions, they have longer dimensions, and they are associated with degenerative spaces or ILM drape and so on. So it's easier to call it foveal neovascularization rather than an ERN. On the other hand, ERN was, like I said before, associated with more thinning and more advanced stages of mactel. So I hope I made sense.
I just have one question, Apurva. So you've talked about two different things. One is your typical ERN, which you've elegantly described in your paper. The other is your foveal vascularization of DR. Now, what if you were to have a PDR patient with coexistent mactel with ERN? I think to my limited knowledge, that's the case.
Yes.
That's the case that Dr. Raja was trying to show, and
Yes.
that's the case that Divyansh has.
Yes.
Just to intervene, so the Mactel study or Mactel group, which they have published, even Dr. Raja is part of it. So in that, they have found out that the proliferative diabetic retinopathy is the least associated with Mactel. Yes, diabetic retinopathy, that is mild, moderate, all those 35% association is there. But proliferative diabetic retinopathy in a Mactel study, it's only 1%. And there is one older study which is by again Arvind group, in which they have found 0% of proliferative diabetic retinopathy. And the Mactel study has also studied regarding the progression of from an NPDR to whatever, mild NPDR to moderate. So the progression from mild to moderate is there, moderate to severe is there, but mild to PDR is again not there. And the means the answer which you're giving is, if the pigment is there, then we call it as epiretinal neovascularization. Is that the answer which we are looking at, or is that the retinal thinning has to be there?
So both. One is what I found in my series. I'm just saying, I'm not laying down a diploma or
So
anything.
because you
It's
have
just
published the
that
highest,
it's
yeah.
just that ERN, I have seen that ERN, first of all, it's easy to call it an ERN and nothing else because none of my patients were diabetic. So I removed that confounding factor altogether. And I was inadvertently labeling any epiretinal membrane in mactel patients as ERN. If I had included all PDRs, that would be wrong. So I removed the confounding of diabetic retinopathy altogether. So ERN, what we saw was associated with thinning and advanced mactel. So there were membranes in mactel, but they were seen in proliferative diabetic retinopathies, which were separate as foveal neovascularization. That's how I brought out some
But those
difference.
patients did not have pigments.
No.
Yeah. So as Sir's case, and because I have three similar cases which had, yes, proliferative diabetic retinopathy with pigments with PFT and with epiretinal proliferation.
Yeah.
So
the other part is, how common is pigment in diabetic retinopathy? So it's not there. No? So your case is a MACTEL case basically. If the pigment is present, I think it's a MACTEL basically.
Yes, sir.
The
Yes,
other
sir.
interesting thing is, your case is the presence of VMT.
Yes,
Yes.
that again is very rare.
I think
Yes.
in a Purva series, they were flat, they were smoother, but in your case, this was pulled up.
Yes,
And
yes.
probably, I don't know what is it, but how I take it is probably the kind of when the PVD will happen, the probably the ERNV or whatever it is, it will also regress. So that is how it regress, I think, probably. But whether it is because of the MacTel or is the PDR combined, we don't know. But it's an excellent case actually. Yeah.
Sir,
Yes.
Dr. Raja's sir's case, sir, do you have attempt to PVD, sir? One of the scans is just showing that there is probably an attempt to PVD at the site where this ERN is formed, sir. Dr. Raja, sir.
Sir actually is now toggling between two webinars. So I think he's I think
Okay.
yes. But yeah, I think
So
I think there will
are you like you did surgery for your case, right, Divyansh? You
Yeah,
removed that.
yeah.
It like you said it increased. You said it.
In the left eye, which the surgery has not yet been done. In the right eye, it has regressed.
so the idea is would Dr. Sangeet or Dr. Raman like to venture any surgical intervention for the fellow eye or how to manage the fellow eye?
Is back, Dr. Raja.
So, Raja sir,
Yeah. Sorry.
sir, sorry, did in your in the case which you had shown, sir, whether there was an attempt to PVD, sir? Because in one of the scans we could see that attempt to PVD getting attached to those ERN hyperreflective material, which is there in the vitreoretinal interface.
Are you saying that was there any initial PVD starting in this patient? Is that your question?
That's right.
Yes, sir, because one of the scan is showing that the PVD is separated, means in one of the scan it is seen that the PVD is just above that hyperreflective material in the vitreoretinal interface. In one of the scans, I means probably the resolution is too less. I just thought so.
Yeah, so in the sense, what I can say is that there is a small line, but definitely it's not a complete PVD, even if it is there. So even I would have to go through the scans again, but there is a small line, but it's definitely not a complete PVD.
I think
Dr. Mudit, I think, presented a case in one of the VRSI symposia, if I'm not wrong, about a case like this, which had MacTel with pigment, and they did the surgery for ERM or something, and along with the PVD, the pigment clump came off. So I would expect that a little pigment and a little vascular membrane on the top of the ILM would come off with surgery. I think that
So
is.
I would like to answer that because, as I told, I have had 3 cases with this, and 2 of them I have done surgery. The second of them, when I tried to peel this pigment, it bled. And I couldn't peel. So on that day also, I asked the same question whether the vascularity was there within that pigment. So Mudit sir told there was no vascularity in the octa, and that's why they thought of peeling it. So I remember the question which you are asking here.
Yeah, so I remember that case. So the thing is that normally these are intraretinal pigment clumps. I mean, you cannot completely remove them. Even if they're during peeling, if you think something has come off completely, then only the epiretinal portion of a pigmented membrane will come.
Yes.
So just to, I mean, I wouldn't go in, at least in the case which I have shown, it's a neovascularization. I would not like to go in and peel that off at any time, unless that creates a more longer or thicker membrane. I wouldn't go in. I mean, it can regress even with laser or anti-weather.
Yes.
I think great points. On that tough case. I think everyone. Thank you,
I
Dr.
think
Raja.
giving laser or anti-VEGF is a true test of whether it's a foveal neovascularization or an ERM.
But
I mean,
VMT being there.
No, not in your case. Not in VMT.
I mean,
What is the answer for the other eye?
Answer the operator. Yeah. I will operate him as early as possible. I mean, it will hyaloid will detach. It will take care of the neovascularization and everything. I think he did wonderfully in the other eye. So you should do it.
Thank you, sir. Yes, sir. Surely.
Yeah.
Thank you, everyone. I'm not even going to talk of the time because we've more than doubly overshot the time. I'm going to just take maybe max of 10 more minutes and just go through a few of the questions that are there. Some which were answered in the discussion, I'll be skipping. There are some which we couldn't take because I wanted that the cases should finish, and maybe we could take some of them at the end. So we started the webinar today with Dr. Swapnil Parchan talking to us regarding retinal vasculitis and CML. And I think 2 points regarding that. FFA is, I think, important because not only is there exudation and hemorrhages, but there is a component of occlusions and ischemia as well. And you will not be able to pick it up in the periphery if you're not doing a FFA. So FFA is a must, absolutely. Also, regarding questions on fundus autofluorescence, I think Dr. Raman took those up. And fundus autofluorescence is not there to diagnose your typical pizza pie or the necrotizing variant of the CMV retinitis. And definitely in such an eye with presentations which will have such florid hemorrhages, fundus autofluorescence is not going to do much. It's basically to for granular retinitis lesions when the hemorrhages aren't that many, and when there is a dilemma whether the lesion is healing or post healing, whether it's trying to recur or not. I think fundus autofluorescence has a role there, not in this case. Again, coming to Ashish's case, in which we were corrected that it's not siderotic vitreous, but basically the capsule, which was kind of shimmering like gold. I think one question which we couldn't take up earlier. Ashish, do we have you there? What was the final prognosis of that patient? Did the retina attach, and B, if it did the patient get back good vision or not?
Yes, sir. So that patient, he came a couple of days back. The gas had totally absorbed. The retina was attached, but the vision of the patient just improved to 3/60, sir, the best corrected vision.
Okay, and the patient wasn't aphakic or anything.
No, sir. The lens was clear. The patient was phakic. The vision just improved to 3/60. Though the patient was happy with what amount of vision he had, but still we wanted to get an ERG done just to look at the amount of.
Point taken. So I think the point's well taken, and the point I think and you have addressed the query, which is that yes, your functional outcome will mirror whatever change, siderotic changes, and also occluded vessels that you saw, and you should not expect miraculous visual recovery. But given the trauma and everything, 3/60 siderosis is not the worst result ever. So you should not give up on these eyes. And also, I think one point which was made very strongly by all the panelists during this case and the trauma cases by Dr. Sangeet were to get orbital imaging in every open globe injury case. If you can and you have access to it, please get a non-contrast CT. If you can't, the minimum of an X-ray is required, not only to not miss out on things, but also for medical legal purposes. So I think that was brought in regarding. So there was this question regarding what kind of foreign bodies would actually develop an encapsulation. Would chronic foreign bodies anywhere in the eye, let's say in the vitreous, on the retina, impacted in the retina or choroid, will the location matter? Or will any chronic foreign body anywhere in the eye, the vitreous, on the retina, or penetrating into the kind of retina and choroid develop encapsulation? Dr. Sangeet, can we have your comments on that, please?
I think ones that are near to the retina or touching the retina, they generally get encapsulated. Foreign bodies lying freely in the vitreous cavity, I don't think so. I've not seen encapsulation in those types of foreign bodies.
Absolutely. So I think the ones which are closer to or more in contact with the RPE choroid, I think you have more chances of a fibroblastic kind of proliferation. And of course, the chronicity and the material of the foreign body itself would also matter. Absolutely. And regarding the indications for chorioretinectomy, I think that was discussed that if it's the closer it is to the posterior pole, the more you can consider it. However, if it's nasal, it's something you might not want to do. Size is also something that you must look at. And again, because you've exposed large portions of the sclera, especially if you're doing it peripherally, must keep in mind the air embolism. So reducing fluid-air exchange pressure and or just doing a PFCL oil exchange, not going to air, is something that can be considered. We're just going to take a few questions on Apurva's case, which was relentless placoid, and I think she showed that very well with that video of the Australian bushfire, and that's exactly what it looks like in the eye. So people have talked about immunosuppressions, which one to prefer. I don't think there's any, will we ever have any data on that. These cases aren't that common. But what is known is the name's telling you. It's relentless placoid. It is primarily, yes, it warrants you to rule out infection in our country. Definitely tuberculosis. The pattern looks a lot like syphilis. But it's primarily, once you've labeled it as a relentless placoid, it is a non-infectious posterior white dot syndrome, a variant, aggressive and poorly responding variant, which with bilateral involvement of serpiginous choroiditis, and requires more aggressive and sometimes even double immunosuppressions or whatever kind you would need. You can use whatever you're comfortable with, azathioprine, methotrexate, or mycophenolate, and or people have looked at going straight away to, after you made the diagnosis, to TNF alpha inhibitors, because they tend to have better kind of. And also, people have looked at intraocular, so you can augment that to circumvent. Adding you might need to augment with intravitreal, Ozurdex, triamcinolone, and or methotrexate repeatedly. Um, Again, there's a question on this, that I think that's in general, that if a patient is diabetic and you need high steroids, how do you take care of that? I think that's a tough one. But the care, so these patients would typically, depending on what kind of steroids you want to give them, whether IV methylprednisolone or very high dose steroids, might require admission. Depends on their background status, depends on whether they are insulin dependent or not, might require hospitalization for the initial part with insulin pumps and regular monitoring. So it's not as easy as it looks. And if that's an issue, if there are multiple comorbidities, systemically, you might need to look at a lot of local therapy. But mind you, a bilateral disease, lots of other things going on. So not an easy case, not an easy scenario, but needs to be looked at. Again, Dr. Ribusoni wanted to know regarding this case. Just in case the MON2 was positive, or the TPHA was positive, how would we have actually gone forward? So if the MON2 or TPHA were positive, this would no longer be relentless placoid chorioretinopathy, a variant of serpiginous choroiditis. It would actually be tubercular multifocal serpiginoid choroiditis, or syphilis, or syphilitic placoid retinopathy with that kind of thing. Then you would target the organism involved. So ATT with steroids plus minus immunosuppression for the tubercular MON2 positive patient, and for the syphilitic HIV positive patient, ART along with penicillin if you get it in your area, and if you don't, then ceftriaxone, and for a minimum of 14 days. But in HIV positive, you might need to give it for 28 days, and it needs to be treated similar to you would treat a case of CNS or neurosyphilis. Again, regarding Dr. Ramanuj's cases of very well documented cases of submacular cysticercosis, I think the point that came across from that was that for really kind of loculated, if I can use the term, submacular cysts which are live, you would have to you might need to actually create a little bit more of a submacular detachment by injecting subretinal submacular BSS, so that when you do make a retinotomy, and which needs to be small, because we all know these can be molded out of a small the cysts can be molded out of a small retinotomy. Whatever instrument you use, it doesn't damage the undersurface of the retina or the RPE choroid, which is below. So the fluid will kind of act like a spacer and allow you to take it out. Someone's asked regarding the size of the retinotomy. I believe Ramanuj was using 23 gauge, so the 23 gauge endodiathermy, the size would be that. Then there was a question regarding, again, Ramanuj had post, and we actually had a little bit of a discussion in the chat group. So if you have if you have a patient of cysticercosis you were following, and the patient refused surgery, or for whatever reason came late and became no PL in front of your eyes, would you offer him surgery just to prevent A, NVG, or B, phthisis? Raman sir, your take on that, please.
I think the offering surgery is not a point here. We have to take, if we develop the NVG, you can do the DLCP or whatever you want to do. But one-eyed patient, the no PL patient, I think surgery is not in case of cysticercosis. And there are other scenarios where you can do a surgery in no PL, but I think we should not touch that.
Absolutely, sir. Point taken. And again, from there on, actually, we went on to, there was also a point raised on this by Dr. Divyansh, which might be a little radical to some, but he comes from Dr. Shanmugam school of thought. So I can see where that comes from, about using the transscleral. So not going transvitreal, but transscleral approach. However, in a submacular location, I don't think that would be prudent. I would like, and I think he's mentioned, and would entail a lot more trauma, right? Getting the rectus off, reaching there. And if you were to do a cut down right at the macula, it would be, I think, fraught with a lot more danger than I think what eventually Ramanuj did.
In fact, Mohit, if I'd like to add something to it, even for cysticercus subretinal, which is away from the macula, we have seen that when the light shines, the cysticercus migrates from its position. So it's never sure whether when you are entering from the scleral side, whether you are in the right place or not. You see, just you will make a sclerotomy and try to remove the cyst would have migrated. So I think it's not a very good idea to remove it from.
Absolutely, sir. Point taken. And then we had that excellent case by Priya, which I think was something that most people hadn't seen, and I think was an eye opener for all of us. Basically, a systemic cause of raised bilateral venous pressure, which actually had back pressure, raised venous pressure in the eyes, massive ciliocoroidal detachments, and actually turned out to be a Nepali lady who was a heavy smoker with a COPD, who had secondary pulmonary arterial hypertension. And with managing that and starting treatment for pulmonary arterial hypertension, she actually got better. And there were actually two questions on that, and one of them from Dr. Meenu was regarding the role of autofluorescence in ciliocoroidal effusion. Yeah, I think that's a very, very, very big kind of thing for a ciliocoroidal detachment of the sizes that Priya showed. Autofluorescence has no role. For small ciliocoroidal detachments, for most part, are either A, clinical, or B, UBM oblique ultrasound diagnosis based on where they're located. Autofluorescence might tell you that they had been here, so they will leave a fingerprint akin to the leopard spot appearance later on. But the role per se of autofluorescence in managing actively a patient with ciliocoroidal detachment, I don't think there is much role. Definitely not in cases with the mounds as big as the one seen in Priya's case. Also, I think the main question of this case, which I think Apurva had asked, and I'd asked her to hold on till the end. She would like to know from the panelists what their approach would be to a patient who has, one, a unilateral ciliocoroidal detachment, no mass lesion, and B, to a patient who presents with bilateral ciliocoroidal detachment without a mass lesion. Dr. Raja, can we have your comments, please, if you're there? I think sir had to.
Yes.
Sir.
Sorry. So I think the question is if it's a unilateral ciliocoroidal detachment without a mass, right?
Yes. So the approach to that patient, as opposed to someone who has a bilateral presentation without a mass.
Yeah. So usually what happens is ciliocoroidal effusions, you can divide it into either ocular causes or systemic causes. So when you have typically a bilateral ciliocoroidal detachment, they can have a systemic cause usually, and that's when Dr. Ramandeep had also pointed out what all investigations you should look for. But one common but missed ones which we see commonly, at least with us, is drug-induced choroidal detachments, and they can present with extremely shallow AC, sudden loss of vision, and they can have high pressures too. So definitely history becomes extremely important, but otherwise in terms of nanophthalmas, you can have unilateral presentation, look for hypermetropia, and we also do look for UBM. I mean, while we are looking for a mass lesion on B scan, UBM also becomes very crucial. It can tell you the scleral thickness too. Sometimes you can have extremely thick sclera. Obviously, axial length is one important thing. The decision to go in for surgery to drain usually depends on, at least for me, I give oral steroids in these unless there is a contraindication. And if within about 2 to 3 weeks I don't see any improvement, then the decision is made to go in and drain these cases. Now, overall, I would say that we need to be very careful in these cases during drainage of the choroidal effusion. that it's not easy one to make the scleral flaps. It's they're extremely thick sclera. You keep on digging and digging. You don't reach the end sometimes. And also, I usually tend to remove only the internal flap. I usually suture the outer flap in these cases whenever I drain. I drain in these cases, tough cases. I do all four quadrants, and I think they do resolve. It takes time. You never get complete drainage immediately, but you have to give at least 2 to 4 weeks time for you to know the results. They go away extremely slowly. In fact, the SRF drainage also you probably need not do in many of these cases. Just the decompression may be enough, but you have to give it some time. But one thing is that yes, drug induced bilateral, they come very often to us.
I think great point, sir. With that, I think we're going to move on to the next. So we had, after that we had the Kalpita present a very vexing case, which actually had three different pathologies, or definitely two, and one systemic pathology. It had PDR, had polypoidal choroidal vasculopathy, and turned out to have a biopsy-proven systemic lymphoma of the rectal region, with what at that point in time, with the consensus was plus minus query intraocular involvement, and was actually a very a very good case. And although there was some suggestion that the early OCTs did show some kind of sub RPE deposits which were there, the lumpy bumpy appearance. So that was a great case by Dr. Kalpita. This was followed by, I think, the case that quite kind of led everyone to just clap their hands, by Dr. Diksha Katoch, of managing that one-eyed, multiple surgery, pediatric glaucoma afflicted eye, in which she had to settle a rheumatogenious RD, and actually had the finally ended up going externally using a buckle, using part of the trimmed Adi as a buckle as well, not explanting that, and incorporating all of the hardware into that eye, and not only settling the retina, getting back vision for that patient, but also keeping the glaucoma specialists happy. And we had discussion regarding having a scleral graft. I think Dr. Raja raised that point as a standby in these eyes, which have had any kind of a episcleral procedure before, just in case one lands up with a any catastrophic complication intra-op of scleral thinning. I think scleral graft is something that should be kept. I think that was a great point. That this was followed by, I think, the most common scenario that everyone faces, the case by Veer, in which there was I think good points brought out regarding the extent of vitrectomy in traumatic endophthalmitis, how much to go for, whether, what kind of antibiotics to give, what would be, how would you want to manage, and actually seeing the patient back. And if you know you have gone to the peripheral a little bit, keep a high index of suspicion of a detachment happening, and not just small tears, giant tears happening. And also Veer showed excellently that you should be up to manage it later on, and not just give up on these eyes and say, oh, we have an RD now, there's nothing we can do. I think that was very well brought out. There are just two last points from the audience regarding the PDR questions, and then we'll come to Divyan. And again, no one had anything to say for Divyansh's thing, because Divyansh and Purva were the only ones who knew what to say. So I think they said what needed to be done. We have two questions regarding the PDR cases, and I think then we can, call it a day. It's been quite long. Um, uh, One of them is from Dr. Lalit Agarwal, and this is regarding the choice of tamponade in eyes which have TRD and oblique CRD, and you're operating. So he opines that he in fact wants to ask, wouldn't gas tamponade induce a macular hole if trapped fluid is left in the posterior pole? I'm guessing what he means is in context of TRD oblique CRD eyes. If you're tamponading with gas, if there's trapped fluid at the posterior pole, he's saying that that could lead to macular hole formation. Raman sir, your take on that, please.
I think the post-op positioning is very important. You have to make the patient prone. If you have made the patient prone for day 1 or 2 days, there will be no such thing happening there. This is what all we do, because we know that the fluid is there in these patients. So it will not matter. The macular hole formation will not be there.
Absolutely.
In
Also,
fact, in many cases, post-operative, we don't routinely do OCT in cases of RD.
Yeah.
you will have fluid on the posterior pole in many of these cases for
Absolutely.
quite a few weeks. So that's not a problem, and so we shouldn't worry about a macular hole in these cases.
Absolutely, sir. I think point well taken. And regarding that, I think there was one point which was put in the chat group by Dr. Ashish Markan regarding that if you do very fast fluid air exchange, then there are chances that you might have some fluid which is actually left behind. So I'd like to ask the panelist, Dr. Rajan Narayanan sir, on your take that how do you titrate the speed, if I can use that term, of fluid air exchange? And would you recommend doing a fluid exchange before getting the air to be switched on and then going on to fluid air exchange? Would
Yeah,
that matter?
yeah, very good question. I mean, these are questions, obviously, once you finish your surgical training, you start realizing. But when you're still undergoing training as a fellow, tend to come across these problems and you don't know what went wrong. So the point here is if you do a rapid fluid air exchange, which means if you remove the vitreous cavity fluid very rapidly and not let the subretinal fluid come out, then you will end up with a problem of the air filling the vitreous cavity and the subretinal fluid getting loculated. So either you do a fluid exchange initially so that you reduce the height of the retina or the subretinal fluid, then the chances are less that they will get trapped. Or even otherwise, when you are doing fluid air exchange, make sure that the subretinal fluid is the one thing which is coming out initially when you are doing the air exchange, rather than the vitreous fluid which comes out. If the vitreous fluid comes out before the subretinal fluid, then you will have a problem of this getting trapped. So ideally, yes, you better do a fluid exchange, reduce the amount of SRF, then start removing the vitreous fluid.
Absolutely, absolutely. And I think great point, and Ashish well brought out. I think that's a great thing that you actually. One last comment on Divyansh's case. I think um, uh, not everyone has seen those kind of cases. Those cases aren't very common to come by. But I think what we could get is that there are three different. If we can have three different scenarios. We can just have a foveal vascularization, new vascularization in a diabetic patient, completely unrelated to a PFT. We could have our regular garden variety PFT with an epiretinal neovascularization with or without pigment. And we can have a subset of that in which there is a PFT with an epiretinal neovascularization with PDR. I think which is the case that Divyan showed fitted into the third category, which was backed up by the case that Radha sir also shared. So that's an extremely small subset. So PFT with epiretinal vascularization, small subset, concomitant PDR even smaller, with pigmentation even smaller. And I think Divyansh showed that if there is some kind of traction, if you surgically get it out, the PVD induction might be one of the stimulus which might lead to regression of that epiretinal neovascularization. Although in his case, since there was concomitant peripheral laser, we would never know as to what contributed more to resolution of that. But I think excellent outcome in his case. And Dr. Raman's view was that the fellow eye should be treated similarly, if not differently, because if you've had success in one eye with a similar or a same pathology, it would make sense to do for the other eye. With that, I think we've come to the end, of this webinar, and it's been we have doubled the time that we took. So I'd like to fold hands and apologize on that count. But I think there were discussions going on. It's very difficult to stop a discussion. I talk a lot myself, so I don't want discussions to be stopped. That was the whole point of this webinar. And I'd like to thank all the panelists. Dr. Sangeet had to leave, so in absentia, thank you, Sangeet sir, for sparing so much of time on a Sunday morning, and enriching us all with your words and your excellent videos, which added that kind of expert kick at the end of it. So we showed what we do, and then he showed this is how it's supposed to be done. So thank you, Sangeet sir. Thank you, Dr. Raja. I know you're toggling between different webinars, sir, especially because this is overshot its time quite a lot. Thank you for being with us right till the very end, and for sharing cases after most presentations, and for giving us those super nuggets of information. Thank you, sir. And thank you, Dr. Raman. I'll thank you personally when I meet you tomorrow, sir. So, and with that, I'd also like to thank all the sorry, all the 10 presenters who stuck through us right till the end. Priya had to leave. Priya had a case to operate. She texted me, so in absentia, thank you, Priya, for adding the international flavor to this webinar. And I think everyone had great cases to present. And I think a round of applause is in order for all of the presenters who had came up with cases which were challenging, which were might seem routine, but very excellent points, which actually were put on the table, and they didn't shy away from actually showing cases which did not work or did not go as well as they would have wanted them to, but still didn't shy away from kind of pushing them under the carpet and actually brought them out so that others could benefit and learn. So thank you all. And at the end, I would be failing in my duty if I don't thank Alcon, especially Mr. Sanjeev, who's been who was basically the one who contacted Dr. Raman for this webinar. And we have Mr. Sai with us. I hope he's here and not sighing. And I'm pretty sure he's sighing. He has a sigh of relief now that we're ending. So, Mr. Sai, thank you from Numerotech for doing this. We had a debacle 2 weeks ago with this webinar, and this webinar going on this long seamlessly without any network issues or any other procedural issues, I think is testament to the fact that Numerotech is the kind of thing that we should have had right from the get-go. So thank you to everyone for joining and for participating. Thank you so much. Raman sir, anything you want to add, sir?
Thank you all, especially Dr. Raja. Thank you so much for accepting the invitation. I think we should all take a break and have a good lunch, and have a nice day, everyone. Thank you so much.
Thank you.
Thank you all. Thank you.
Thank you, sir. Thank